Information about today's session, speakers, and more, please visit bit.ly/2021 Transforming Care. That's bit.ly/2021 Transforming Care. Each session will be a live webinar, and you'll have the opportunity to ask questions in the chat to our speakers. If you need assistance during the program, support from Rainbow Health will be available via chat, social media, or email at communityeducation@rainbowhealth.org. Today, we're going to talk about some important and difficult topics. Please know that you are not alone, and if you're in need of immediate support, please call the Trevor Lifeline at 1-866-488-7386. For ongoing care and support, our behavioral health clinic is also there for you. And now, it's my honor to introduce to you Maggie Drushko, Project Clear Program Manager and Therapist at Reclaim, who is here today to talk to us about building inclusive systems of care for queer and trans youth.
Good morning. Thanks so much, Miko. I'm going to share my screen really quick so that you can follow along. All right. So to start us off, I'm going to give you just a little bit of an introduction about myself. My name is Maggie. My pronouns are they, them. I think that it is important to start our time together by naming my own social location within society and acknowledging the intersections of power, privilege, and experience that come into the room when I'm here. I am a US citizen. I'm of white, Greek, and Irish heritage. I am white, of Greek and Irish heritage. I have middle class privilege, and I grew up in the Northeast, which is actually where I'm coming from now. I live in Minneapolis, but I'm on a birthday vacation out in Maine. I have educational privilege from being a master's educated social worker, and I have a responsibility to dismantle the racist. Sorry, am I talking really fast? There's a good chance I am. I have a responsibility to dismantle the racist and carceral past within my field through my various social work privileges. I am able-bodied. I'm a bicycle enthusiast with some connections to the Twin Cities bike community that I love to be a part of. I am queer and trans and non-binary. And again, I use they, them pronouns. For another week, I am a program manager and therapist of Reclaim's sexual violence prevention program. And then I will be moving into a role as a therapist at Cedar Hill Clinic in South Minneapolis. I'm also a patient and client in medical and mental health systems of the Twin Cities. So I am both personally impacted by what we're about to dive into together and professionally invested in the understanding and implementation of it. A content warning. We're going to be talking about identities, gender, sexuality, other identities, that's redundant, and medical and mental health contexts. Here are some suggestions that may make this a safer space for you because these topics are vulnerable and personal for all of us. When we are in discussion with each other, which I will ask you to do during the chat in different parts of this, please tell stories that are more about how you have felt or how you feel rather than about details of what has happened to you. Take care of yourselves and step away or mute if you need to, and feel free to leave if you need the space. This allows us to all be in a space together where we can talk about things that are challenging or that bring up emotions and do so in a way that tries to care for one another while also not like easing over the conversation that we're having. So our plan for today is going to be to talk first about queer and trans inclusion in a more generalist setting, and then talk more about what does inclusion look like in practice. I'm speaking as a person who's worked in both medical and mental health settings, and we'll be kind of bringing in some ideas about how do we take these sometimes very extremely binary spaces and make them more inclusive. But I also know that many of you in this room are not new to this work. And so I would love to hear what has been working from you. I really see this as both a chance like for me to share some information, but for this to be a communal knowledge sharing opportunity as well. Because we know how to make spaces inclusive, and sometimes the systems we're in don't make that easy to implement. So I'd love to like tap everyone's knowledge together. And then we'll talk about what do we do beyond the individual relationships? What are ways that we can work at a clinic or systems-wide level to try to make spaces more inclusive? And then we'll have time for questions and final thoughts. I also invite you to throw questions into the chat as we go, or to excuse me, put the questions into the Q&A. We have a moderator, Tia, who's going to be following along, and she will be tracking any questions that you ask to bring at the end. But also, I would love sometimes to see what questions are coming up in the middle as well. For me, that's really helpful. My internet is a little slow, so advancing this slide takes a second. All right, so to jump into queer and trans inclusion in a general sense. I like to start with definitions, even of basic content, because everyone has different meanings attached to these words. And I want to set a baseline for our conversation here today. If you have different definitions than me, that doesn't mean that either of us is incorrect. Rather, it illustrates that language is ever expanding and growing into new descriptive ways. So chat your thoughts. I'd love to hear what other ways you think about these words.
Hey, Maggie.
So to begin with, oh yeah.
This is Hannah moderating for Tia, actually. I'm not seeing the next slide, just so you know.
Oh, that is great to know. Wow.
I'm seeing it now. Thank you.
Okay, sorry. I'm definitely on some like sketchy rural Maine internet.
No worries, it looks good now.
Thank you. Okay, great. Also, I'm like, wow, all my little illustrated people that were really visible on my computer are kind of funny looking in a slide that's big, but that's great. This is how we roll with life in virtual times. Thanks, Hannah. So I think it's helpful for us to gain some shared understanding of like when we're using these words in this session, what are we talking about? So when I talk about gender identity, I think that it's important to highlight that everyone has an internal sense of gender. Some people are cisgender, meaning that their gender corresponds to the sex assigned to them at birth. Other people are transgender, which can be binary trans, like transmasc or transfemme, or trans and neither, or many more genders. Some people who are not cisgender identify as trans, others do not. Non-binary people may or may not identify as trans, and non-binary is both an umbrella term as well as a unique identity, meaning not identifying exclusively with either of the two binary genders, male or female. But then there's this whole expanse of gender within that category as well. Some people feel that their gender is more fixed or static, while for others it is highly fluid. Gender is elusive and a deep journey. In our social reality, though, gender is almost always thought about through gender roles, socialization, and gender presentation, rather than identity itself. Gender expression is a physical manifestation of one's gender experience and is usually shown through appearance, mannerisms, personal traits, clothing, hairstyles, voice, body shape, etc. It also includes how other people perceive your gender, which may not match the gender expression that somebody is intending to present. And I think it's important to note that the body you're born with or circumstances you are living in may present limitations to the way that you can express your gender identity in its fullest. And so this is part of why it's important to get creative and think about gender in like fun and expansive ways, because it helps us break out of some of the more binary ways that we think about gender expression and not just gender identity. When we talk about sex assigned at birth, which is almost never something you need to know unless you work with somebody in a medical context, this is the assignment and classification of people as male, female, intersex, or another sex based on a combination of anatomy, hormones, and chromosomes. And then pronouns are how we refer to somebody when we are referring to them in the third person, but not using their name. All pronouns can be used for any gender, and all pronouns are gender neutral unless a person has said, these are my pronouns, in which case those pronouns apply to that person in their gender experience. I also work really hard to not use the term preferred pronouns due to people generally not having a pronoun preference, but simply having pronouns. Using preferred can accidentally insinuate that the correct pronouns are optional. Also, I just realized that my computer is showing me that there are things in the chat, but I actually don't have it open. This is so great.
Maggie, if you want, you can also just prompt me to say, Hannah, is there anything in the chat?
Oh yeah, that would be great. I just realized that would be so helpful.
And so the only thing relevant to you right now is there's a request to go a little bit slower.
Yeah, thank you.
But other than that, we're great.
Yeah, I'm so sorry to the interpreter and anyone following along. I have this bad habit of getting on a roll, so I so appreciate requests to slow down. Thank you all. All right, so what I really think is the takeaway from how can we make spaces inclusive is do the work to stay on top of ideas that are always changing. Learn from the people in your life, learn from young people especially, listen to podcasts, watch TikToks. There recently was a really wonderful podcast that some of the young people with Shift Minnesota through Rainbow Health created called Queering Community Health. And it's still out, coming out with new episodes. And I just want to shout out Azul and all of the Shift interns who have really been helping me continue in my own learning. I think that listening to young people and watching the things that young people are creating is a great way for us to stay on top of how language is changing to make sure that we stay at the forefront of inclusivity. It's important to read the writings of trans folks and things beyond gender. I like to read published research, but I also want to make sure that I'm reading things before it takes 3 years in a research pipeline or before academia thinks that something's important. And so I have found the best way to do that is to see what young people are saying and doing and keep having young queer and trans youth in my life who get to be a place of learning and a great opportunity for cool relationships. So shifting into more of what does this look like in a practice setting, like a medical, mental health, or care-oriented care set or work setting, there's probably a lot of ways that you are already trying to make your practice more inclusive. I would love to hear in the chat if there are any barriers that you encounter, and are there any resources that have been helpful in thinking about how you address these? I would love group discussion and the pooling of resources during this presentation today. The wisdom and the knowledge that I have here just comes from working within federal funding and behavioral health and insurance systems. So it's not like I'm an expert on this. I'm just somebody who's fighting battles all the time with the rigid and binary systems around us. So feel free to chat. And Hannah, I would love if you hear great ideas that people have that you shout them out.
Yeah, sounds great. Are you supposed to be on another screen? I'm so
yes. Are you still? Oh man. All right. Is it saying first interactions now with little people wiggling? Cool.
Yes.
I'm not sure why my slides aren't advancing, but I will try to double check each of them each time. So I like to think about creating inclusivity from the moment that somebody first interacts with our organization or office or comes to does a Google search about where to find queer and trans health in their community. And so I think we should start by thinking about how is our website designed? Are there bios for everyone that have pronouns at the top of them? Do we have contact forms that ask for people's names and pronouns in the contact form when they first reach out to us? Are there statements of inclusivity that are visible and comprehensive and non-performative and well prioritized on the page? I find this one to be a really challenging one for myself because I think it is hard to do anything on a website that isn't performative. But something that I've been working with the young folks that I work with through Project Clear at Reclaim is trying to come up with how do we write a statement of inclusivity that is coming from them and not just from myself with my social work jargon, and trying to figure out how do we better write inclusive language that isn't tokenizing and isn't performative, but can be really clearly stated in a visible way as a top priority of how we write and design our website, not just how we talk. And then for when people's first phone calls happen to us or on referral forms that we get from other providers, I think it's important to ask for the pronouns and name that a person goes by. And unless it is necessary to create a medical file at that first phone call, we don't need to ask for any legal identifying information. And that doesn't have to be something that we only do for folks who might be calling and identifying as trans or identifying that they have multiple names. That's something that we can do as general inclusivity for all people. I'm I'm going to make sure that the next slide shows up. So we spend a lot of time in the early relationships with folks gathering a lot of paperwork and information from them. These look like different forms that we have for intakes, demographic collection that we might do for different grant funding things, different ways that we try to gather insurance information so that we can bill and help somebody's care be covered, as well as all of the consent forms we might get to try to have outside providers or relationships or referrals with others in the community. And so I think that it's really important that when we start with any of these papers, right at the top of every form is a ask for name and pronouns, and that we make it really clear and explicit that you can use your name that you go by or the name that someone goes by in their in every form except the ones that are like legally required to be with a legal name or the name on insurance information, and that those forms are something separate, and that we're explicitly telling people, okay, these 2 or 3 forms over here are the ones where you have to use your legal name, and the rest of these can be filled out with the name that you go by. And I think this is an important way that we start giving data transparency and telling people what we're using the information we are collecting for, and separating out that people assume when they're in a formal setting like a medical or mental health setting that they need to use their legal formal name, and that's not actually true. For the forms that people are filling out with me in therapy that are just agreeing to do therapy with me and talking about the therapeutic process, I want that to be centering their like daily identity and lived experience. I don't need it to be the legal name that they're like not currently associating themselves with. And so I think it's important in those moments that we be explicit and clear with folks that we only need your formal name in these like specific intake things, and that all other names can be filled out, or all other forms can be filled out with your name that you use. Additionally, having space for gender identity to be filled in as a blank line rather than the binary boxes that the federal government makes me ask people. My program that I work under is federally funded, and when I report at the like 6-month biannual report that I do, I have to pick between 2 binary genders or an unknown. And nobody I'm working with has an unknown gender, but by explaining to people, these are the 3 categories and for federal reporting, I have to pick one. What do you want me to pick? It puts that control back into the hands of all of the young people that I'm working with. And it allows them on a separate place to also write all of their actual gender identity descriptors, which are what I use in my like day-to-day chart that I hold for them. And so I think it's about really being specific and allowing people space to self-define and consent as much as possible to like what demographic information or what formal information we have to collect on them. This goes back to the idea of informed consent, which means that when we are asking people to give us information, we want to give them enough information about how that will be used so that they can make an informed decision with a full understanding of what they're consenting to in the process. I also, when specifically with data, like to ask people if they have any experience with being a part of a research program, or have they ever tried to like do any learning on the internet about queer and trans youth, only to realize that there's not a lot of helpful statistics. And part of that is because queer and trans people are often erased in the forms of large federal data collection sets. And so by talking with the young folks I work with about the value of queer and trans representation in data, it gives them a chance to decide if they want to consent and share information with the government that may one day be part of a data set, or if they would rather keep that information private. And so I think it helps to give people a sense of like, where is this information going to be used, and what is what is my intention in asking you for it? I feel like I've been talking, I mean, of course I'm talking at you a lot, that's sort of the purpose of this, but are there questions at this point on like forms and gathering data? Okay, I'm not seeing any, so we're going to keep going. Let me make sure that you get to the next slide. All right. So when we do a lot of external communicating, that's what I mean more by like talking to other providers or doing care coordination with folks that work with the people that we're also working with. As a therapist, I work closely with psychiatrists, with doctors who are providing gender affirming care, whether that's primary care doctors or endocrinologists or surgeons. I spend a lot of time talking to care coordinators at various different clinics around the cities. There's also all of the referrals that we might make to help connect people into the social service systems in other ways. There might be records requests that you make for past information. And so in all of those external communications, we have to get releases of information. And I think it's important to have a conversation at the time that you're getting the release signed. And again, when you're going to like make the call or make the request to the person that the release is filled out for, to ask the person you work with, what names are you wanting me to use when I'm speaking to whoever this release is for? Does your teacher, parent, therapist, doctor know you by a different name than you use with me? Is there a different name that may be additionally used with this? For example, with records requests, I can refer to you by your chosen name and your like correct name the whole time, but should I also know a second name that might be on a record if people are searching for it? And then asking, what pronouns would you like me to use when speaking to this person? Or if this person doesn't know your correct pronouns or doesn't frequently use them, do you want me to only use your name or initials to, your name or initials to avoid pronouncing you at all? And does this person know your correct name and pronouns? And if they use the incorrect version, would you like me to correct them in the moment? And I think for me, this has been really helpful, especially for young people whose parents may either not know that their young person is using the pronouns or the name that they are, or where the family is like not using the correct ones on purpose or just needs some practice. And I get to be taking my cues from the young person in those moments rather than like making any assumptions based on things they might have shared in past conversations about how they communicate with this person. I see a question. Oh, yeah, totally. So the question is, have you ever heard of someone not wanting to provide their preferred pronouns due to them stating that in their culture, preferred pronouns aren't a thing? That came up in an event I attended at the Midwest Mixed Dialogues for individuals that are Black and mixed. Thoughts? Yes. So I definitely have had young folks who have said like, oh, like that's just not really, either pronouns aren't a thing or like we don't have different pronouns. And I think in those moments, trying to take your cues from the person that you're talking to and saying like, you know, if you were to talk about or think about yourself and like tell a story about yourself, what pronouns would you use to describe yourself? And if there aren't pronouns at all being used when you do that for yourself, great, we can use your name. But if it's I talk about myself with these pronouns and my family or my community doesn't understand those pronouns, I think that's a separate conversation for talking about how do we like shift between cultures and do some of the code switching, and what are ways that like we can code switch and make ourselves smaller, or code switch and like make ourselves into like give ourselves an opportunity to self-advocate and maybe encourage our culture to consider new ideas as well. And so for me, that because I'm a therapist and I can have long conversations with people, that often leads to a lot of great conversation over time about how do you navigate living in multiple cultures, and like the ways that language can grow and change, but also that language is challenging to like push at a larger cultural level. But how do you maybe start just in your family who already has like, there's something called a familect, which is like the dialect that your family uses, or a small group that you are part of, like a micro culture develops its own language. And so I often ask, are there ways that your family has learned to use new words to describe something. Like in my family, we talk about digging in the fridge for leftover dinner as like scrounging, but other people call that fending or like leftover picnics or whatever. We all develop our own words for how we talk about certain things. And so I think giving an opportunity to young people or whoever you're working with to think about, oh, is my family or my culture maybe more open to like a language shift than I realize? So that's a really long answer. But
Hey,
I'm going to
Maggie.
pause there and take a sip of water. Yeah.
That was great. We've got a question or maybe a couple questions related to each other in the Q&A that I think
Yeah.
you might just prefer to answer now versus waiting. So somebody said, I've heard of the term dead name, and then kind of follow up, is that the given name once the person is going by the chosen name?
Yeah, so I try to not use the term dead name because I think I like to let people decide for them if that's like if that name is actually like something that they've retired sort of, or is that a name that they're just no longer going by? But essentially when somebody in their family like gives them a name when they are born, then that is the name that they have until either their family starts calling them by a different name or they start going by a different name. I know like my formal legal name is Margaret because my parents thought I might want a serious name in case I was a very serious person. But I've always been called Maggie, and I'm named after a family member who only went by the name Maggie. And so for me, like Maggie is my name, and Margaret is just the formal name that's on my bank statements and my social security card. So for me, that's like, that wouldn't be a dead name, but it's also not the name I go by. So when I have an opportunity in medical settings to like give my like actual name, it's really nice to me when I'm at the clinic and they come out to call me back for an appointment and they say Maggie, and I actually answer and walk. When it used to be I like assumed I had to go by Margaret and they would call that, and I'd kind of just keep reading my magazine because I didn't realize that was my name. And so for like, there's lots of different ways that people's names can grow and evolve and change. And so I try to avoid using dead name, but you'll hear that, and that can be some people, when they use dead name, mean the name that they're no longer going by. It may be a name that carries a lot of like pain or hurt. And so that's why like I really like to let people define language the way that they want it to be used. And so if they use the term dead name, then I'm going to follow their lead and also use that. But for other people, it may be my past name or my old name or my before times name or just the name I don't really use. So does that kind of get to the question of, I like to ask like, what is your name that you use? What is the name that your friends call you? What is the like your name that you talk about yourself in, as a way to try to get beyond like chosen name, or but also for some people that process of choosing has a lot of meaning and value attached to it. And so I like, again, taking my lead from people, if they want to talk about my chosen name as this, that's awesome. And then I often feel really honored when somebody like shares the story of how they got to that chosen name with me. I hope that that answered that question. I'm seeing a question too about, with respect to gender options on a form, is it acceptable to list male, female, and other, or would it be best to list non-binary, etc.? Sometimes space on a form can be limited. Yeah, so I will say, I think that the more that you're able to give that like write-in space, that's awesome. I feel really seen as a non-binary person when non-binary is one of the options, and that's great. But I also always check the other and write in that I'm genderqueer too, because I have multiple gender identities, and non-binary describes my gender by what I'm not and doesn't necessarily describe it by what I also am. And so if you only have space for like 3 options, and I would argue if you have space for 2, you also have space for 3. So if your like forms right now say male, female, make sure you add that other and have that be a blank so that people can write it in. If you have the option to list a bunch of boxes and a write-in section, that's kind of the dream. I've noticed in the last year and a quarter with a lot of the state Department of Health forms that I get to sign up with all kinds of pronouns. pronouns and all kinds of gender options. And it's been really cool to see the Minnesota Department of Health really take that on as like a part of how they do. This was when I would sign up for like vaccine sites or testing sites or anything like that. It was really cool to just see that like part of the COVID response was also like allowing me to feel really like seen and included in just how the Department of Health gathered data. So I think it's awesome if you're able to give people boxes to check that welcome and show that they're like included in the way you think about gender, but also anytime you can give people a chance to self-define and write in their identity, I think that's the best, because then we get to capture the ways that language is always changing. There are a lot of young people I work with who teach me identity terms that I did not know prior to working with those young people or prior to like meeting them, because there's so many new words and new ideas, and some of them are not new, but they're maybe new in the vernacular and they're being used more commonly. And I find that especially like middle schoolers are so great for being at the very cutting edge of language development. And it's a great way to learn all of the new different gender words. Oh, and this is a great piece. If you have checkboxes, you should definitely say check all that apply. Always give people the option to like check as many as they identify with. Don't like push people into having to pick one bubble to fill in. And yeah, thank you so much to the COVID community coordinators at Rainbow Health. I really appreciate that. I very much felt the presence of Rainbow Health in COVID response within the Twin Cities and like Minnesota as a whole. It was really cool when one day I hopped on Autostraddle and saw a comic illustrated by a local Twin Cities comic that I like. And then it was all about like COVID, and it was sponsored by Just Us. So thank you, Rainbow Health, for being awesome and at the cutting edge of public health. So do we have more questions on like how we do forms and pronouns and releases of information before I get into more of the like communication pieces? I'm using this moment to pause and take a sip of water. Okay, so not seeing any questions, please bring them on. We can always like loop back. But I spend a lot of time care coordinating and consulting with other providers who might work with a young person or might work on similar topics. So I'm part of a couple different consultation groups that meet and talk about working with trans youth, or talk about like trans surgical health interventions or trans hormone interventions. And I find it's really helpful to be in communities of other people working on these specific things that I also work on, because it helps me continue to be like advancing my own learning. And it also gives me people to like bounce things off of if I have a question. But I think it's important that we always get consent from the people that we work with before we're consulting with anyone, even if we've already sort of mentioned that we do this type of consultation. I know at my intakes, I tell people I like am a part of some consultation groups, and your information in this therapy session is all confidential, and a topic that you bring up may be something I later seek like outside consultation on. But I also think it's important to, again, like tell a person if you are seeking that consultation, because it gives them a chance to be a part of the conversation. Like I will just say, hey, you raised this like question about like type of surgery, letter, specificity, need, or whatever, that I haven't written a letter for this type of surgery before, even though I've maybe written letters for other surgeries. I'm gonna search for somebody who I can talk to about this. Is there a way that you would like me to talk about your situation with like specific pronouns? I tend to remind them that this whole conversation is confidential. I won't share your name. I won't share any specific identifying information. I will talk only about this specific thing that we are getting consultation on. But also, I will probably need to use pronouns to refer to you at some point in that conversation. Do you want me to use generic pronouns? Do you want me to use specific pronouns? How do you want to feel like you're being represented in that conversation, even if we're not discussing anything specific that would ever point back to that person. And I think, again, this also for me helps decenter me as like an expert, that I'm the therapist you come to and I have my knowledge, but I also live within a much larger care system, and expertise is shared among many people. No one person holds all the knowledge. And so that helps kind of decentralize me, which is part of my whole therapeutic way of working. But I think this also allows me to really help put the client or whoever I'm working with like back in a place of control in getting to define how they would like their gender or sexuality to be referred to, or their pronouns to be referred to, even when I'm talking about them in like a non-identifying way. So those are some of how I like engage in peer-to-peer conversations. I think it's also important when we're making referrals to other systems of care that we do that whole process with the young people or the people that we're working with, and ask them, how do you want to be spoken about or communicated about on this form? Or when I make this phone call to try to get you access to this psychiatrist's appointment, like times, how do you want me to talk about you? And just in every like situation, anytime you're speaking to anyone for like the first time or for the first time in a while, I think it's a helpful thing to check in with the folks that you work with and say, how do you want me to frame this conversation, and how do you want me to talk about you? Because again, this gives the opportunity for people to like change how they might feel or what words they might be using. I know for me that like the way that I describe myself has fluctuated over the last few years, and that it's a great thing to be able to like have someone check in and say, how do you want me to talk to your doctor? Because it might be with different words than the ones we were using 2 years ago. And so again, just like anytime we are referring somebody out for another service, or we are coordinating with an existing treatment provider, I think it's great to bring it back to the person that we work with and say, how do you want this conversation to be structured? Any questions here? I'm going to pause again and see if things are coming up on like, how do we talk about folks and talk to folks about other folks. Cool. Well, I am going to bring us forward. Oh, wait, there's a Q&A. Okay, curious if you have thoughts on navigating family dynamics, specifically how to bring affirming, supportive care to youth who may not be getting affirmation and support at home. Yes, so this is a huge, I work with a lot of young people who still live at home and are often minors who like need parents to fill out their forms for them or to like consent to things. And I think it's really important that we like separate. I might need consent from your parents in order to see you or to treat you, and your parent is not present in the room all the time that we are meeting. And for me, that's possible because I do therapy with the young person. It may be that if you work in a medical setting where like a parent is present for the whole time, this may be harder. But I also think this is where we can get creative about thinking through, are there opportunities for us to meet with a person separate from a family member, and then bring a family member in at the end? And how do we give young people who may not be in affirming spaces anywhere else a chance to feel affirmed and like in control of at least some part of their own life experience when it comes to gender or sexuality? Part of how this plays out for me is that I will ask young people, like, do you want me to use your name and pronoun? Do you want me to talk about you in third person more during our session? Or do you want me to like address you by name at the beginning of every sentence when I talk to you? Because that may be a way that they feel seen and validated in like a very specific way that they might not be getting elsewhere. But I think also this is where that like checking in and communicating with the person you serve before you talk to anyone else is really important, because this is where like I have a young person whose whole family does not refer to them by the correct name or pronouns. And for that person, they feel more comfortable when I just like follow suit with their family. And that makes me uncomfortable because it means that I know that this isn't like my client's full, like their whole identity isn't being represented. But if that's what the young person has asked me to do, then that's that I want to like, my highest value is on their sense of control in this situation and their consent. So then when I talk to that person's family, try as much as possible to just not use names or pronouns at all, and like let the family do what they will. But with a different family who like doesn't also like, again, doesn't use the correct name or pronouns, that young person has asked like, but I want you to use my correct name and pronouns. And so I call and say, I'm calling about like your kid whose name is this, who uses these pronouns, and use that. I like intentionally use that more during conversations with that family as a way, because that young person has asked me to, of like joining with them and taking a stand. And so I think it varies a ton depending on like what the young person wants, in their family. And so I think that's where it comes back to this, like, we want to take our lead from the people that we're working with and not make assumptions. And so when we can, like, as much as possible, let them know that you want to affirm them in space. And like in our appointments, I will do whatever you want me to do to help you feel seen and validated. And these are some examples of what that can look like. Because I think that's the other piece, is if we ask people to tell us what they want, they may not know, because it's never occurred to them that they could ask for such an opportunity. So I think it's also important that we tell people, these are some ways that I have helped other people to feel affirmed in session. Do you want to try any of those, or do you want to try something else entirely? As just different ways to help get people comfortable with being seen and validated in relationship to me, even if that's not happening at home. Okay, any other questions before I move us forward? Okay, I'm gonna take us along. Let's see, there we go. So yeah, so thank you, Jay, for this. Sounds like a great consensual approach that offers young people a lot of empowerment in the situation. My work is as a therapist, but also as a healthy relationships and violence prevention peer education trainer. And so I teach consent and boundaries all the time. And I think that's like a huge part of what then governs how I move through the world as a therapist too, is that I think placing consent and control into the hands of young people, or like whoever you're serving, is such an important part and is not natural within medical and mental health systems. That's not how we're trained. And so it takes unlearning that and realizing that you can be like incorporating consent into the process so much more than we are taught to. So we've kind of hit on a lot of this already, but when we're thinking about documentation and charting, it's the same things that we're doing in all of our forms or in all of our relationships. We're trying as much as possible to use people's correct names or chosen names, or the name that they go by, when we're writing our treatment notes, or when we're using any like pronouns. Using the name and pronouns that that person like uses in conversation is really important. But we also have insurance requirements that we need to use someone's like name that their insurance bills under, and have that gender on file for insurance billing. And it needs to be present at least once. I know in my behavioral health notes that like there has to be somewhere on the page where that insurance name is present, but then the rest of my note I get to write in the language that my client is asking for. And again, this is about, I think, getting like being creative and doing the work it takes to learn, oh, the insurance company needs this, but how many times do they need this? And so looking for ways that we can, as much as possible within our documentation and charting, center a person's name. This may be like important when we think about how we have unique identifying numbers for like what is a person's MRN number, medical record number, or what is like the name or the number that I look them up in our electronic health record with. And if you can advocate with your electronic health record IT folks, you want it to be a chosen name that is what you're searching for or what comes up, rather than a legal name. And these are things that might feel impossible in our current systems, but are actually not very complicated from like a backdoor IT fix. And so it's important to like think about how do I wish this looked, and can I just mention to the IT people that it would be really great if it worked this way, and keep asking and keep advocating for that. As much as possible, we want to store information in different ways, where like face sheets or front pages have chosen name and pronouns really big. And if legal name has to be on it at all, that is like small, or ideally on like a back click page that I have to get to with a second click instead of on that front page. So that when I'm like going into this person's chart, the thing that I'm visually seeing first and like that's being visually prioritized is their actual identity rather than anything that may not be like a key part of how they want to present. And this is really important too when we think about how we run reports or like look at client data, because there are people within our organizations, our systems, who may never meet that client, but might know that person by a name that's not actually the name they use. So something we've realized at Reclaim is I know all my clients by their names and I can like search them by that in the electronic health record. But when reports were run, it was coming up with insurance names because we were running billing reports based on how somebody was being billed to their insurance. And that meant that like supervisors mostly knew people by first and last names, which they may or may not be using. And so it just meant like changing our reports so that they also run the first column is like the preferred name, which is the way that our electronic health record calls it. And that allows us to sort by like the name somebody actually uses and for us to visually see that first. And so it might just be simple things like wondering, even if nobody's ever, like our supervisors and that client may never interact and nobody's explicitly being harmed, but the more that we can create inclusion, it's in like all levels, even in those upper admin spaces where we can make sure that a person's full identity is like carried with them in all the levels. Oh, do you think that insurance processes contribute to some of our healthcare oppression? If yes, how? And if no, why do you feel that way? Well, yes, I think insurance is a huge part of healthcare oppression. I don't think that insurance companies should need to know gender at all or sex assigned at birth or any, like, why should that matter? Why do I need to put that on every billing statement? There are so many ways. One of the hardest things when you go through a legal name change or gender process is to update your insurance information, because it requires you to have extra updated other documents like your social security card and your birth certificate. And like the health insurance system is very binary and not very trans inclusive, even to like binary trans people, but it is particularly exclusive when it comes to non-binary people who the healthcare system doesn't even think like exist in terms of how insurance is designed. So yes, a huge way that we can advocate for like queer and trans inclusion on a much larger scale is advocating to our state and federal legislators that like health insurance systems are broken, and the way that health insurance is currently designed forces people to have to like give information that isn't necessarily accurate to them, or give information that is like legal but not chosen. It's also an expensive and complicated process to go through name changes or to get birth records changed. And it's not possible in every state to change the sex assigned at birth on a birth certificate and things. And so for some people, this is like financially difficult and not necessarily an achievable change. And for other people, it's actually like legally not possible in the state that they were born in or the state that they live in. And so I think insurance companies play a huge role in healthcare oppression. Yes. Yeah. And if we have time at the end, I can talk more about that too. Moving into just thinking about like how we meet with people, I've covered a lot of this in other slides, but I think it's important every time we're meeting with people to introduce ourselves with name and pronouns and check in with the client and patient about that each time, because this normalizes that names and pronouns can shift and change. And when we do this with all of our patients, not just the ones who we think are trans, this gives opportunity to everyone to communicate their gender identity as they want. And that gives people opportunities to just like be humans who grow and change and shift in how they might self-define or self-describe. And then I think it's also important when we have like intakes or diagnostics and psychosocial assessments to ask people early on in our experience together about how do they experience gender identity, and can they describe that? How do you experience gender and intersecting other identities? Can you describe that? I think it's important to remember that like gender does not happen in a vacuum. And so people's other identities may also really be an important part of how they think about and self-describe their gender. And so we don't need to like require that people communicate all of that to us, but I think it is really great to ask that from the beginning and to offer that as like a thing that I think is important to hear if you're willing to share. And that sometimes I've been meeting with people for like months before I get to hear more about the other intersecting identities, because those might be more private or more vulnerable ways that they share themselves. But it shows at the beginning that like I care about not just like the gender that I might assume by looking at someone, because that's not a thing that you can actually do. I want to hear how you self-define. And whenever somebody is talking about other people in their social system, like I hear a lot about people's family members or friends or partners or roommates, it's important to ask for people's pronouns in those moments too. And so when somebody's talking about like my mom, blah, 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 like I'm like, well, what pronouns does your mom use? Because that helps again normalize, like we can't make assumptions about pronouns. And for me, it's really helpful in everybody's chart that we keep mostly electronic health records, but I have like a piece of paper for each of my clients that's just a social map of like who are the people in their life and who are their pronouns, because it's really easy for me with like a bunch of clients to get people mixed up. And so it's helpful to like track that. And I love to make that collaborative together with my clients, where like when they're telling me about a new person, I can like, we can together put that person onto the map, or we sometimes update the map and say like, oh, I'm not hanging out with this friend anymore, so like let's like start a new map and put that friend out at the outside. Or this friend is now using a different name and pronouns, which happens a lot with young people and is really fun. We get to have this moment of like celebrating their friends' own gender experiences when we update our maps together. And it makes it a lot easier for me to discuss with the people that I'm seeing in therapy, or when I used to work in medical settings, people who I'd talk about like their doctors and their therapists. And it would be really helpful for me that I had that written. I know as a therapist who gets referred to a lot by people's like doctors with the wrong pronouns, I really love when my clients have realized that I want to know what their doctor's pronouns are, because then it makes me wonder. For some of my clients, they like correct their doctors when their doctors misgender me. And that feels like a cool moment of like gender solidarity, and kind of crossing through, like gender is not within the power dynamics of like therapist to client or things like that. It's also just like part of how we're human in community together. And so then if you're ever discussing somebody's body parts or bodily functions too, asking them what terminology they use to refer to those parts of their bodies and what words they use to describe those functions. And when possible, describing what is happening with like neutral bodily language, while also clarifying what language somebody wants to use. This helps people like determine and define how they want to talk about their body, and moves us away from like medical model assumptions of reducing people to body parts or associating body parts with genders, which is inaccurate. And then asking yourself, why are you talking about this, or why do you need to know, and how you think you would justify needing to know to a colleague or a supervisor. This is the informed consent information that you can then provide to that client or patient when you're asking for it. So saying, I need to know this because we're about to talk about this like specific thing. Can you provide this information and help me know how to talk about it with you?
Hey, Maggie.
Okay, yeah, we're at time.
Yeah, we have about a little under 2 minutes left. So
okay, this is perfect. Are there more questions? That just gets me to like make your bathrooms gender inclusive and easily accessible and have good signage. Make all your bathrooms inclusive.
Yeah, so people are
the end.
They can connect with you, Maggie, if they have more questions or want to learn more.
Yeah. That is awesome. So I currently work at Reclaim, but I'm actually in like my last week of work is next week. So if you want to connect with me more, you can email me, and I'm going to type this here, but this recording is also going to be available, I think, for 6 weeks through your enrollment in this. You should also get a follow-up email about how to access the recordings. So feel free to reach out to me. I would love to hear more questions or to like chat about specific things coming up in anyone's practice. And also it helps me to gather data and know how to like keep making this more of an engaging and like useful presentation if you give me some survey feedback. So feel free to scan this QR code, which would by like holding up your camera, and that will take you to a website so
Don't
that
see the
well,
QR
see,
code.
it's not showing up. There it is.
There
Okay.
it is.
Thank you. That gives me a chance to just like keep making this useful. And feel free to email me any other questions or thoughts.
Thank you so much, Maggie. Yep, everyone will get access to this recording and all of the recordings at the end of the event today. We are now at time for this event. So we actually are taking a super quick 5-minute break, and then we'll be back at 10 o'clock with the non-binary and trans patient perspective panel. So we will see you all then.
Thank you all.
For those of you returning from this morning's session, welcome back. If you're just now joining us, note the presentation's recording will be available following the close of today's events. As Maggie just detailed, improving conditions for queer and trans folks is critical for all care providers and ultimately advances care for all. The best way to address the needs of trans and non-binary patients is to hear from those patients themselves. During the following panel discussion, you'll hear from 5 diverse trans, non-binary, and two-spirit individuals who all have unique healthcare experiences and perspectives, moderated by Rainbow Health's very own Iola Kostrzuski. Please welcome Adi Coons, Jamie Hagan, Ms. Renika Evans, Baki, and Chava Gabrielle.
Hello, everyone. Here we go. We're grabbing everyone. Hi, so I'd like to start off with I'm Iola Kostrzuski, they, them pronouns, and thank you all for joining us. This session will be a conversation. So with that said, I'd like everyone to go through, introduce yourself, your pronouns, and what do you do in the world today? Starting with Baki.
Hello, everyone. My name is Baki. I use the pronouns they, them, theirs. I am a student at McAllister College, as well as an intern with Minnesota Transgender Health Coalition.
And then anyone can go next. I'd like you to introduce yourselves.
Yes, good morning. My name is Renika Evans. Into my volume there, I'm sorry. I always speak behind. Let's see here. Okay. Good morning, everyone. My name is Renika Evans. I go by she, her, them, they pronouns. Today, I work for Minnesota Public Health. I am the COVID-19 LGBTQA program coordinator. And thank you.
Hi everyone, my name's Shava. I use they and she pronouns. I'm in the Rondo neighborhood of St. Paul. And I am a poet in my spare time, performance and writing artist, as well as an organizer at a local nonprofit around healthcare.
As a former Rondo resident myself, I would say hi.
Hi, everybody. My name is Jamie. I use he, him, his, and they, them, theirs pronouns. I just graduated from grad school, and now I will be a child welfare social worker in Modesto, California.
Anin, at the constant ko at the kinto them on the gamin singi tashin bigego. Wasa the schwab no watch bug and then way magnag. Apchin the mikachwain, the mamaya, nongom. Dash in the no kioma, jubimotari da oma get the kimanang. So my name is Atikons. I come from the Caribou clan. I grew up in northern Minnesota, but my family's from eastern Canada. I'm First Nations Cree and Mi'kmaq. I am two-spirit, and I'm currently working with Ojibwe Daoma Gitakimanang as the coordinator of the adult and parent programs.
Awesome. Thank you all for joining me today. So I'm going to first start off with, how are you today? And this is also, I think, the first time that all of you are meeting. So how are you?
I'm gonna be real honest. I'm not used to waking up before like 9 o'clock in the morning. So like I'm tired. But I feel really good. I'm happy to be here. Yeah, I'm hot because my apartment is hot right now. Yeah, and I'm just really excited to hear. I know a couple of the people on the panel today, so I'm like really excited to hear what they have to bring, and I'm excited to hear what the people that I don't know have to bring too.
I would say I'm hanging in there. Lots of different things going on in the community, but it's good to be here today and share this space with you all.
I would say it's been a hard transition. I just moved to California last week and I'm just waiting to start my job and find housing and, I don't know, find a place to live that's affordable. So this is a nice break to be able to share my experiences and not have to think about real life and finding a place to live.
Backy. Anyone else before we get into our questions?
That's a great question. I haven't checked in with my body or my mind or spirit for a minute, just been going. So it's nice to have this reminder to check in with myself. I think I'm doing all right. I think I'm a little bit tired, a little bit anxious, just because, anytime being recorded is, a lot for me. But I'm good. Thank you for asking.
So this is Renika again. I'm doing good. When you asked the question, how are you doing? I immediately started thinking socially and not physically, because physically I'm doing fine. Emotionally, I use the word anxious as well, but socially, like the outside world, I don't feel safe. For many reasons. And so to have an honest conversation for me, about how do I feel physically, good. But I think it's a lot of moving parts around me. So yeah, thank you.
You're welcome. And with that said, I'd like everyone, including the audience who's watching, to just take a really good breath. So a deep breath in, holding it for 2 to 3 seconds, and then letting it all the way out. Just because this is going to be a conversation that brings up feelings, it may take a tangent. We don't know where it's going. And I just want us to all be really grounded on where we are and knowing that this is a safe space to talk about your experiences. All the questions I'll be asking today, you were all given prior to this. But this is a conversation. I want you to interact. I want you to go off on the tangent. It's not too far. I'll reel you back in. But I want us to have an honest conversation. So starting with the first question, thinking about the intersections of your identity, so race, gender, ability, religion, and your interactions with healthcare, whether that be doctors, hospitals, the healthcare systems themselves, social workers. What do you think professionals in these fields need to know? I know it's a very heavy question starting off.
I can go.
I can start off a little small sentence of a big conversation. It's that I would like for them to know that they do not have to be trans professionals. So if they're learning new things, that's great. You do not have to become a pioneer in the room with me and try to impress me that you know that I'm trans and you watch RuPaul and all that type of stuff. So I just want them to be able to relax. Language is important, and if they have any questions, they can feel free to interact on that. Lately, with my healthcare home, they're doing a great job, but I think that they're reaching far and beyond. Some of the things are not helpful. In other words, they're good to know. They're good that you know them, but sometimes the context of a conversation doesn't fit what we're doing. And I just want them to know they don't have to be experts, and learning is good, language is good, and keeping up with the times and being respectful is awesome. And it's like an uncomfortable space, almost when someone learned grammar and some vocabulary words and they just start using them. and they're not even fitting into where they belong, but they almost think they are cool, but they're not. So there you have it. Those are my thoughts for now.
Shava, I think you're going to say something.
Yeah, I was gonna say, so in a lot of my experiences working with medical professionals, like I'm not out to them. The first time I came out to a medical professional was actually a therapist that I had who was also non-binary, and uses they, them pronouns. And like, that was like a space where I felt like very comfortable coming out. That being said, I do have a lot of chronic health issues. So I'm in and out of doctor's offices on a regular basis. And I think like one thing to like address is like, one, like you don't know if somebody, like you don't know until somebody tells you what their pronouns are. You don't know until somebody tells you what their gender identity is. Like just because we're marking boxes on a sheet, like does not mean that's how we feel. That doesn't mean that that's how we identify. I think the other thing that I would say is like, just like with being Black and being read as a woman and like entering medical spaces, medical racism is a very real thing. It's a very heavy thing. And it's something that we, Black people, like all, I believe, experience. And like in that, like, I just want to say, like, in my experience, like, I know my body better than any doctor's gonna know my body. I know when I feel right and I know when I don't feel right. And that goes for pretty much any patient. So like I would say like one of the biggest things is like make sure that you're listening, make sure that you're like really engaging and like really like there to like, because for me, my relationships with my medical professionals should be a relationship where we're both engaging to get to like me at my peak health or like my best health that I can be at. And that's like part of why I'm not out to my doctors, because I feel like if I have to navigate talking to them about my pronouns, like this is how you address me. And I will say like I am privileged in the fact that I am comfortable using she, her pronouns. So like I don't feel it's like not too like disorienting, or it doesn't like give me like a super bad amount of dysphoria to engage with the doctor and like have them use she, her pronouns for me, or assume that those are my pronouns. But like, because I have to like work through medical racism and like, that's not a choice that I have, I actively choose not to engage with my gender when I enter those spaces, because of the fact that I don't want to have to navigate my gender and my race at the same time. And not everybody has that privilege. And so I think just like thinking about that, and like having that like context when you are approaching a patient, like whether you like know how they identify or not, is important.
Thank you.
To build off of that, I think it's important to understand the historical context, just that medical racism is not only something that we deal with today, but it has been built up through, through a history. So oftentimes when I go into spaces for medical help, I already see my provider at a hierarchical disadvantage to me, as well as the face of an oppressor because of medical violence. And I think that is something that like medical providers can't overcome, because like metaphysically in this reality, there's been a lot of violence and harm caused. So like understanding that there is a historical context built up to be so that one can be seen as an oppressor is really important. And that can't be overcome with just a simple conversation. That takes time and advocacy.
And to give context onto what has been spoken on of historical history with providers using Black and brown bodies to experiment on forceful sterilization of uterus holders, there is a history here. So if you're not familiar with this, I strongly encourage researching and reading. There's a lot of information out there about this.
I think you can also start with just understanding Henrietta Lacks or Lakes, I believe, who was a Black woman who is the reason why we have vaccines today, because she had because she had cancer, and right, I believe, can someone help me out too? She had womb cancer. Can someone help me out? Uterus cancer, and those
Yeah,
cells.
I do. Yes, she had cancer.
Yes, and those cells were regenerative. Cervical cancer, thank you. And you could tell I'm nervous, but and her cells help provide her cells were wrongfully used without her consent to research to create the polio vaccine as well as other vaccines. And that's the reasons why we have medical care today. So this whole system is literally built off of the medical system is literally built off of the backs as well as wombs of Black people.
From my experience with the medical healthcare field, I think where I really felt the most validated and the most supported with my care providers is when they don't make assumptions about things. You know, going in as an Asian person who's adopted, I can't explain what my biological family history is because I don't know anything about that. So when I have doctors who are receptive of that and not asking me probing questions that I can't answer because I genuinely don't know the answers, I really appreciate that. And also related to gender and gender affirming care, to having providers who are open-minded about the broad spectrum of gender and identity and not assuming one thing about biological reproductive parts or one thing about gender labels or something else about, you know, sexual activity and that kind of thing. Just having a more open-minded stance in that way, I feel more respected and more accepted in that sense, because then they're not assuming who my identity is or who I look like, what I look like based on how I present myself in the doctor's office. So that's really helpful.
Yeah, and just building on what everybody is saying is that one of the biggest things is really taking, like for medical professionals and everybody, to take that time to digest their unconscious biases and recognize that that is an everyday piece of work. You know, that's something to work on every day. And that's why I see that there's 98 participants here, and I'm hoping that these people are here to, you know, work on themselves and work on their learning and learn how to work on their biases and learn what language to use and not make those assumptions, because that is, you know, what so many of us deal with going into these spaces. I know one of the questions we had was talking about positive experiences in the medical field, but I would say I have more negative experiences, you know, in these offices, in these spaces, and in that hope that these professionals can come in and take away some things to learn. You know, when we go into these spaces, like, we don't want to be assumed upon. Like, there's so many things, whether it's gender identity or disability or your race, your ethnicity, assumptions, you know, they don't help anybody in any way. But if we can have that space of care and compassion and reflection and checking in, you know, maybe you work with your patient at one point, you haven't seen them for a year and a half, so maybe it's time to check in again. But if you're seeing your patient regularly, you don't need to ask them every time if they're pregnant, if they're not exposed to semen. You know, if, you know, it's just things like that what really are kind of belittling and dehumanizing as you go into these spaces, and you're just like, all I was looking at was to get my cough checked out or my sore throat. Like, why do I have to go through these experiences that are you know, just like kind of pushing yourself and your gender identity into all these boxes.
No, thank you. Yeah, so I think the big thing from this one question is the assumptions. The assumptions, not here to educate, do your own your own work for education. Your patients are not to educate you. And being authentic and bringing yourself to the table, being authentic, being vulnerable with your patients, and don't pretend that you know all the things, because none of us know all the things. So then this leads me to the next question. Have you ever experienced seeking healthcare where you felt fully seen and validated by your healthcare provider? What that made that experience different, and how did it make you feel?
As a survivor, I think that I feel the most comfortable with informed consent, not just being like, oh, here's the procedure that's happening, but also like going deeper to when it's like, I'm gonna put my hand here now, or you know what I mean? Because I hate when I'm in the nurse's office and they just randomly touch my hair or touch my arms because they can see that I'm uncomfortable. That just makes me more uncomfortable. So when informed consent goes down to the very nitty gritty of like, this is where my hands are and this is how they will be placed upon your body, that is the best for me. And the best care I've received is when informed consent goes down to the intimate act of when I will be touched.
Yeah, I have to agree with what Bakai said. Is it Bakai or Baki? I'm sorry.
Baki.
Baki, my bad. Baki. Yeah, I think I remember the first time I went to Family Tree Clinic to get a Family Tree Clinic. It's in St. Paul. It's honestly one of my favorite clinics to go to for reproductive health. And the reason it's one of my favorite clinics is because one of the first times I went there to get a pelvic exam, they were very like in that motion of like informed consent. Like they were like, I am not, like they did not touch me until they told me I am going to touch you right here. They said, this is what it may feel like. If you don't want to be touched right now, like say no, like you can say that. Like I was given permission to vocalize like when I felt comfortable, when I felt uncomfortable. And like in those hierarchical settings of doctor's office, which are very hierarchical settings, especially if you are a Black person, especially if you are a queer person, because there is that power dynamic of like, I am the doctor, I can give you your medication if you need it, I can withhold it, even though they're not supposed to do that. Like they have the power to do that, and that's always in the back of my head. So like being given permission to like be like, no, I don't want that right now, or like this is how I want it, like that was very empowering. And then another time where I felt like really comfortable was when the therapist that I mentioned earlier, who was at Reclaim, they are a Black therapist. They use they, them pronouns. And it just felt I felt so seen to sit down with a person who like I was able to relate to on like an identity level. Like we were able to have conversations around like, these are like around like lived experience, where it was like, okay, like we don't have the exact same lived experience, but we have enough similar lived experiences where I don't have to over-explain how I feel about myself. I don't have to over-explain my background. I don't have to over-explain my relationship to my father, because they understand what it's like to have a Black parent. They understand what it's like to be non-binary navigating this world. And like, it was very much like an eye-opening thing where it's like, oh, this is what care is supposed to feel like. It's not supposed to be a thing where I get anxiety or pit in my stomach before I walk into the doctor's office, which has been the case so many times. Because like Adekun said earlier, like I personally have so many like negative experiences that like when I read the question of like what is a positive experience and what did that feel like, I had to like sit for a second and be like, I know I've had a couple. Let me think about that. So yeah, that was really good. Thank you.
Oh, there you go.
I'll jump in. Like Shavo is saying, something that has felt positive is when you're in those spaces and you don't feel like you have to have your guards up or anything like that, right? I had this really great doctor and she's since moved out of town. It was really disappointing, but I remember first time going in, I was like, oh wow, like this feels really good. Like what's different here? You know, you just like there's something innate that's there. You're like, oh, this is a positive place. Like just the way she interacted with me, like she actually read my file, right? So she knew how I identified, and the questions she asked were very appropriate and to who I am, and just checked in like aware, like I don't I've been with a partner steadily for a few years now, and she, like together we're like a lesbian couple, and my doctor in that space like didn't ask if I was pregnant, asked if I used toys, and to check in on some of those health things rather than making these other sort of assumptions. And then we went in to have a pap smear, and she just talked and joked the whole time and made sure it's like that consent, right? And talked about like where her hands were going to be and what was going to take place. And then it was so quick, I was like, oh, what even happened? She's like, yep, I'm done, and it's just like that healthy, safe feeling of like this doctor had good energy in that space and made sure that as an individual I was respected. And it's it was just really life-changing. And now I'm back with another doctor who, again, I realize is starting to recognize what that feels like. You have your pit in your stomach. You're like, oh, they're not talking to me right. They're making these assumptions. I'm not very comfortable in these space. Do I really want them all up in my business? It's like, it's uncomfortable. And so it's those little things that really make a difference, is just knowing who your patient is.
I want to add to what everybody else is saying also, with the experience of having that consent piece of telling me what they're going to do, what they're going to touch and everything. I had that experience at the U of M Boynton Clinic with the nurse who I worked with from my gender affirming care. And I really appreciated that, because the doctor I'd seen before was just rushing through everything, explaining things. And I decided I wanted to switch my care to a different clinic for insurance purposes, but also just to see somebody else. And I really appreciated seeing that nurse. I think she was a nurse practitioner, and for her to be willing to explain what she's going to do without rushing through it. And I felt valued as a patient and as a person. And also when I started my hormone treatment too, she, other than explaining her medical stuff that she has to explain, I got to talk more than she talked. And I really appreciated that, because I was able to share my experience, what I wanted to see out of hormone care, what I wanted to achieve as a goal for my transition journey here at the U of M with hormones. So I appreciated that she wasn't telling me what it was going to look like or what I was going to become, I guess, out of this hormone care. And also that she asked questions about family and just life in general, and wasn't just medical doctor stuff, medical words and all that kind of thing, but she was also curious about my mental health. So they do the PHQ or whatever mental health assessment at the beginning of the appointments usually. And she would ask, how's it going in general, and not just stop it right there and be done. But I really appreciate the genuine curiosity about how things are going, aside from the medical doctor language that they have to talk about.
Thank you. So I also received several positive medical services from a nurse practitioner, where, I'm not a patient anymore, but what I found was interesting, she was able to talk to her assistant. For each patient, this nurse practitioner she has an assistant to support them. And she explained to me that she had conversations with her assistants about transgender and what does that look like, and about bodies and what to expect from like this person's body, so that they wouldn't be giving this like surprised look when my bra and panties didn't match per se. And so she had an assistant in the room. And I think one of the things were, I don't know if this was to protect her and myself, but there was a second person there and I was comfortable. It was not for everyone. And there was a consent on that conversation before it happened. And I thought that was very important because for some people, they're not comfortable with the bodies at their hands, and they have a doctor or a nurse to present your body to a third party. You most definitely need to have a conversation about how comfortable you are with your body and other people watching someone else probe your body. And so I thought that was very professional. I think she didn't assume anything. And yeah, I really enjoyed being her patient. And I mean, if I was living in the same space, I would most definitely go back. Thank you.
Informed consent is the running thing I'm seeing in this part of the conversation. Informed consent can make or break your healthcare. It can make or break whether you see a doctor for the next 5-10 years, or you stay away from a hospital and clinic, which we know can lead to like not great outcomes. And then it was brought up of having that second person in the room, the second, whether it's a student, a resident, an intern. And you brought a really great point of the conversation that truly needs to happen before you bring that intern or resident in the room versus, and I think we probably all had this where you're in the appointment and then it's brought up, oh yeah, there's a resident with the doctor today, is that okay? And it's usually a minute before the doctor's coming into the room. That's not informed consent. It's sprung on you. And there's a power dynamic there of, well, what happens when I say no? But it's not explained to you what happens when you say no. So it's this unknown and you're kind of almost forced to say yes. So yes, informed consent. Okay, so I all want to take a breath. Ground yourself. And so I want to like lead off with my last question. So you have a medical professional in front of you. They do not have their white coat on. They are on your level. What would you tell them? What do you want them to know? I know this is a heavy one. If you tell them anything, what would you want them to know? And it can be anything.
I think I would want to have a conversation around like the parallels between the medical industrial complex and the prison industrial complex and like just how carceral receiving healthcare can feel. I think like as a person who has never been a part of the prison industrial complex, like thankfully, like that's a privilege of mine. I still have been hospitalized against my will. And during that period of time, like it felt like it was very much so like in a setting of like, you're locked up, you cannot leave. You have a little bit more freedom than what is like, would be assumed to happen if a person is incarcerated. But like at the same time, like I wasn't making decisions for myself. I also like during that period of time was something needed to happen for my care because I was mentally unwell. I was experiencing a psychotic episode. And so like I was very much like not present. And at the same time, like being not present and then feeling trapped and feeling locked up is not necessarily the process that was going to happen. And I remember like having like this distinct fear throughout the entire period of time that I was there that this wasn't where it was going to end. Like I was going to end up incarcerated in some way, either because like I lashed out and they misinterpreted my behavior, or because they saw something in my chart that they didn't know about. And like, granted, like a lot of these thoughts that I was having like weren't grounded in reality. But like were in a sense, like they were grounded in my fears that I already have carrying into a medical setting. So I think there's that. I think like also like that very deeply pairs with what we were talking about earlier about medical racism and the history of medical racism and the history of like Black bodies being tested on without consent, the history of Black bodies being put into mental health facilities without consent, and then being a form of like, this is where we keep the people that we don't want, instead of it being a space where like people are genuinely receiving care and like getting to a point where they're getting better. And like I can say like that is a conversation that I've had with a lot of people that I know who have also been put into mental health care facilities and did not feel safe, did not feel cared for. And like, yeah, so I think that's the conversation that I would want to have. I don't know if there's like, I think like the conversation I would want to have so that they can go in and do their own research and like unlearn a lot of what is taught in medical school, a lot of what is taught in like the use of physical force in mental health spaces. And like that paired with the myth that Black people don't feel pain in the same ways that other races do. The myth, and like that myth perpetuates a lot of the care that is received by Black people in those spaces as well. And that use of physical force, how that use like also parallels the carceral system. I'm kind of ranting now, so I'm gonna stop and give space for other people. Thanks.
Well, I would say to a doctor to listen, to actively listen to your patient. I had an example. So my family on my mom's side has a history of colon cancer. And I would ask for an examination. This went on for months on end. And I also have another health condition that may override that because it's current, it's in front, it's primary reason why I'm at the doctor, right? Is usually that's my primary condition, right? But I have a few other concerns. I would like for doctors to consider allowing your patients to prioritize their diagnoses. I give you an example. So if a person is living with HIV or AIDS and they're taking HIV medications, if they're no longer medical adherent, it's not always find out like they need a pill bottle or if they need me to call them or do you need a gentle reminder? Do you need a medical partner like someone to take a pill with? That's not always the solution. I would like for them to take a step back and then ask the patient. I'm gonna use myself for an example. I'm a transgender person that's living with HIV. It may sound weird, but for me, to ask me to take an HIV medication to support a body that I don't want to begin with, you probably want to listen to me when I say that. So now, what I think is interesting, hormone replacement medications, I have no problem remember taking them. Not at all. I take them like as soon as I wake up, it's like, yes, today is a good day. You might want to hear me as a patient when I tell you that. So why don't you not hold back the hormone replacement medications as a carrot and say, take your HIV meds, or then I give you this. Why don't you prioritize what's important to me, right? So if you see what I'm seeing and say, you know what, let's have this conversation. I'm not talking about a work plan because a work plan, once again, favors the doctor. It's almost like when you rent an apartment, and I'm going on, but I just want to make sure that we're on the same page here. It's almost like when you sign a lease for an apartment. Most of the things on the lease has a lot to do with the landlord's rights. You know, like you can't do this, you can't do that, you need to do this, you need to do that. And then you need to, if something happens, then you need to call tenants' rights, right? And so I'm using it for an example because in some situations, like Lola said, there's a power there. And if your doctor is not allowing you to speak or they're not actively listening to you, then like what's important to me will be my hormones first. If I have my hormones, I'm gonna take them with my HIV meds, no problem, because I'm excited about the hormones. So that's just an example. I need for them to actively listen, allow your patients to have a decision in their treatment, and just figure out what's priority for them. My colon exam finally didn't happen. I had to not be a nice person to get it to move forward, but it did happen. And so I would like to tell the person with no jacket on, without the white jacket, to be an active listener and allow your patient to prioritize with them as a team on, keeping you here in the body that they want you to take care of. Thank you.
I think for me, if I were to sit down and have a conversation with somebody or a medical professional, the biggest thing that I would want to talk about is my experiences as an adoptee, because my legal last name is my adoptive family's last name, but it's not my biological family. So when I talk with doctors, they ask me about my family history, and I have no way to describe what my family history is because I don't know what it is. But I wish that doctors would also consider what the family history effect, or the biological or adopted family history, how that impacts our mental and physical health too. So when they ask about like, do you have a history of heart issues or diabetes or whatever, I can't answer that. But when they say like, do you have a history of depression or anxiety, I can't say biologically yes or no, but I can say I do have the effects of mental health from my family. So, what I see going on at home, or what I've experienced, or the effects of my siblings and my parents' mental health on me and that kind of thing. So just acknowledging that my family history is not going to be the same as my adoptive family's family medical history, but also recognizing that our history together can be combined in other ways by mental health, or it can be, you know, um, I guess causal, like because of this experience with this family, this is what I'm experiencing today. So recognizing the difference between, I can't answer that question because I don't know what my biological family is, but I can answer this question because I've experienced it in this way. That would be the biggest thing that I would want to talk about. And also just in general for doctors to be aware, whether it's somebody who, like myself, identifies as trans and is able to recognize the spectrum of gender and not automatically assume, okay, you're trans. So if you are biologically female, you must be a trans man, or if you are biologically male, you must identify as a trans female. So just having providers who are willing to recognize the non-binary spectrum and also other genders in between, and not automatically assuming we're just jumping to the other binary gender, and recognizing that there's some fluctuating factors that may influence somebody's decision to not automatically identify as the opposite binary gender as well, and having those conversations with them. For example, hormones. If somebody wants to be on low dose hormones, being open-minded to that without saying, well, you're not going to get the full effects or whatever of this. So just being able to be open-minded of whatever somebody's hormone care wants to look like, leave it up to them. You don't need to justify what it's going to look like or not look like, or that kind of thing. And just giving the space for the patient to make and share their own stories and experiences without having to prove it or explain why it's valid.
I think I personally would want to know, I think I personally would want to know why they were in the field. I would ask more questions than I would have answers. I'd be like, why are you here? Why do you do what you do? Do you care about all people or just folks that look like you? And then I would also just want them to know that, like, again, there's a hierarchy in place, and that to dismantle that, it does take active listening, active care, and active research. Like there's new research every single day, and I feel like that medical professionals are in a unique position where you can never know too much. There's never a stopping point. There's always going to be a learning curve, and I would hope that this person would see that, or this hypothetical person would see that as not a challenge, but as a as a call for growth.
Yeah, when I think about this question, I think about coming down to that we're all people. You know, it's like sometimes when you go in there, they're just rushing about and they barely finish their sentence before they're out the door. And like, it just is so frustrating. It really does make you not want to go back. You know, it's like, why would I go back to this space where they're not even going to take the time of day for me and to actually figure out what's wrong? I mean, how often, you know, I'm sure I'm not the only one who's had to go back and then back again and then pile up $1,000 medical bill because I don't have good health insurance. You know what I mean? It's like something that could have been answered on day one. Instead, you're dragging me back here and back here again and creating this debt that I can't afford, you know, and then it's just all these barriers and it's just really frustrating. So it's like thinking about having that conversation. It's like, how can we be humans on day one together and share that space? But on a separate note too, I know we're running out of time, but I wanted to share quick what it means to be two-spirit, because I realize not everybody in these spaces might know what that means. So being two-spirit is an identity that has now been a pan-Indian term. But what it is for Indigenous people in North America, it's a way of identifying that's culturally based too. So it's not just LGBTQT plus, you know, it has a cultural meaning, and that holds that space in the medical field too. So when we're in these spaces, that's something else that for medical professionals to recognize is like, we're not just coming in as, you know, queer peoples. I also identify as queer and lesbian, but I also identify as two-spirit. And for me, that means that I carry these certain roles in my community and I have these certain teachings. And for me, I predominantly identify as she, her, but if somebody sees me as he, him, or they, them, that's how, for me, that means that's what spirit I have forward in that day, in that moment, for them to see me that way. And every two-spirit person identifies differently. Some may, you know, be cisgendered, but also be two-spirit, or some may identify with he, him, and she, her pronouns, but not they, them. You know, it's like everybody has these different experiences and what everything means, but it's important to recognize that, you know, in these spaces, we carry something else too when we think about birth of children or care. It's like we have these cultural things that we would like to do too in these spaces, and for medical professionals to take that time to learn, you know, what it is specifically that we would like. For example, when they took out my wisdom teeth, I was like, I need my teeth back. You know, for me, that's part of me. I need those back. Well, some people may be like, that's fine. You know, you can throw them away or whatever you do. But fortunately, I got that. But I've had other individuals be like, they took that part of me. And now for me, I am lost. You know, and so there's different things to just have communication about what it means, different surgeries and different pieces of your being and everything like that as well.
No, thank you very much for that. We have about 5 minutes left. I know there was a question. I do want to give, the question was answered with the panelists organically. So I do want to give the last remaining time to the panelists. This is their platform, a platform that's rarely ever, you know, given. So with that said, is there any closing remarks from our panelists regarding this or any other things, or just last words that you'd like to say?
I want to just say thank you to the other panelists. Like, I learned so much from y'all, and I really appreciate this conversation. I'm grateful to be in space with other queer folks, other trans folks, other non-binary folks. Yeah, and I also want to say thank you to Ola for holding space for us as well. Yeah, I just am very grateful.
Hi, I would like to say thank you. And again, thank you for providing a space, one, for that I can express myself in a safe space. And I was able to learn some things. So thank you so much.
Backy, anyone else before I close out? I know you have words.
I don't know what to bring into this space other than that, as a deep feeler, I think I just want to call into the space that like folks are still dying by the hands of the state. We have to protect our water. I think what else? Yeah, I think there's just so much context of when it comes to health and mental health that we weren't able to touch on. So yeah, just think about those things as well. I hope, yeah, and thank you for opening this space up.
Well then, with all of this said, I want to thank you all for coming. I have learned so much. Some of you I know, some of you I don't, and it was great to get to know you. And the ones I do know, it was great to get to know a little bit more about you. I want to thank to all who've attended. Thank you. Thank you for giving your time, but also wanting you to walk away from the session on basically examining, if you are a provider, how are you going to help your patients and clients reclaim their safety within your space, and what you can do as a provider to help that. And I think our panels here gave many different ways of what that looks like, whether it be informed consent and like true informed consent, or addressing our own biases. And we all have our own biases. So with that said, I want to say thank you again, and also remind everyone that this information here can save trans and non-binary lives. So thank you, and yeah, have a great day, y'all.
This is Tia with Rainbow Health here, popping in to let you know that we're going to have about a 15 to 20-minute break before the keynote panelists. If you're comfortable, if you have any contact information you want to share or any pages you would like folks to follow and support, feel free to drop those in the chat. Otherwise, everybody, you've got about, like I said, 15 to 20 minutes. We'll be back with the keynote at about 11:15. Thank you all so much. See you soon.
Good morning, I'm Miko Blaze, and I'm excited to welcome you to the Rainbow Health Transforming Care Beyond the Binary keynote. We look forward to being together in person again soon, and we're so glad to have you here with us today virtually. I would like to introduce the next song. It is called My Pride, which I wrote, and it is an assortment of my Facebook Twin Cities community and what pride means to them. I took all the words that they put and I put it into a song. You can catch it available on all streaming services off my album, He, Him, His. Be strong, be bold, be fearless. We are strong, we are bold, we are fearless. My joy is an act of rebellion, I love who I am. I'm using my freedom, express myself, I'm exactly as I am. I cannot be shamed, I'm authentic every day. I will not be afraid, I'll stand proud as I am. Freedom to love who I want. Freedom to be what I want. This is my pride. This is my pride. We keep surviving, striving, hoping for the unity of our community. Let's educate, liberate, be as queer as you wanna be. We are strong, we are bold, we are fearless. We are strong, we are bold, we are fearless. Yeah, we're strong. Freedom to love who I want. Freedom to be what I want. This is my pride. This is my pride. I want to take a moment to thank our sponsors, Alina Health, New Way, Right at Home, Walmart Pharmacy, and Target. To achieve health equality here in Minnesota, it will take advocates of every sector. I also want to thank the folks at Stage Time Productions, AV4U, and VidGuru who made today's event possible. Thank you to our table hosts who have spread the word far and wide about Rainbow Health and invited others to join us today. And finally, thank you to Maggie Drushko and panelists Adi Coons, Jamie Hagan, and Ms. Renika Evans, Baki, and Chava Gabrielle for sharing your knowledge with us during the morning's educational session. If you are just joining us, we encourage you to visit bit.ly/2021 Transforming Care to learn more about today's educational sessions before and after this keynote. Again, that's bit.ly/2021 Transforming Care. Today, we're going to talk about some important and difficult topics. Please know that you are not alone, and if you're in need of immediate support, please call the Trevor Lifeline at 1-866-488-7386 for ongoing care and support. Our behavioral health clinic is also there for you. Now, I would like to introduce Jeremy Hansen-Willis, CEO of Rainbow Health.
Thank you, Miko. And thank you all for joining us today to hear about Rainbow Health's vision for the health of our community. It's been quite a year since we stood on this stage last summer. This past year has challenged and strengthened us in ways we never could have expected. The intertwining pandemics of racism and COVID-19 shined a brighter light on the disparities in our healthcare system and the resulting disparities in the health of our people. Like many socially aware organizations, we used this past year to take stock of ourselves and the role we play in our community. We looked at the legacy of our past, the context of our present, and the challenges of our future. For too long, healthcare systems have erased and excluded LGBTQ people, especially trans, non-binary, and people of color. As Minnesota's first HIV/AIDS organization, we have seen firsthand the dangerous combination of illness and injustice. It was 38 years ago that the first Minnesotans affected by HIV created the Minnesota AIDS Project to lead the fight against HIV. For 38 years, we have upheld this mantle to improve the lives of thousands affected by HIV. In 2018, MAP merged with Rainbow Health Initiative, a long-standing LGBTQ health education and research organization, and Training to Serve, a trusted program supporting the needs of older LGBTQ Minnesotans. Formerly Just Us Health, now we are Rainbow Health, a diverse team of professionals united by a passion for health equity. While our name has changed, our purpose has not. Rainbow Health exists to end HIV and LGBTQ health disparities. We help people navigate healthcare systems by breaking down barriers. We want every person to be cared for and respected, and we'll fight to make that happen. We bring our purpose to life in two ways. First, by directly serving and supporting people with non-judgmental and compassionate care. And second, by fighting for better and more equitable healthcare systems for everyone. This two-pronged approach is delivered through 4 key strategies. 1, we work to end HIV by building on our 4-decade legacy of providing the most comprehensive array of wraparound services for people with HIV. We know that the only way to end HIV is to end health disparities for LGBTQ folks, Black, Indigenous people of color, and all marginalized people. 2, we offer unique and specialized mental and chemical services of, by, and for the communities we serve. Our care is trauma-informed, harm reduction-based, sex-positive, and meets people where they are. We turn no one away for inability to pay. 3, we work to empower people on the margins with relevant resources that allow them to lead healthier lives. Our legacy of fighting HIV and LGBTQ health disparities have given us insight and experience we bring to the broader movement for health equity. And 4, we educate and train healthcare and senior care providers about how to deliver care for the diversity of LGBTQ and HIV communities through a lens of intersectionality. We know that the people and communities we serve lead complicated lives and often face complex challenges. That's why we employ a comprehensive approach that targets the root causes behind health, like housing, finances, and social connection. Rainbow Health works to ensure that all people should be able to go to any clinic, any hospital, any treatment center, and receive quality care that respects who you are as a whole person. Along with a new name and renewed energy, we have new initiatives underway to expand our impact and fight for health equity in LGBTQ and HIV communities, including new supports for LGBTQ elders and those aging with HIV, a groundbreaking partnership with the state of Minnesota responding to HIV, a unique virtual Rainbow Health hub connecting people to LGBTQ competent healthcare and senior care providers, and a new HIV pharmacy and teleprep service offering free PrEP and medical visits. These are indeed challenging and uncertain times, but out of disruption, new ideas emerge. There is pent-up energy for change in our healthcare system. Building on the legacy of HIV and LGBTQ activism, we will fight for what we need and what our community needs. We need you to be part of that fight. Together, we can and will tackle these challenges and create a Minnesota where everyone has access to the health care they need. Thank you again for joining us today and for lending your voice to this effort. Have a happy Pride. Back to you, Miko.
Thank you, Jeremy. Next, I'd like to introduce to you 2 key advocates in Minnesota who are going to talk about how their work overlaps with the work of Rainbow Health and how we can all come together to transform care. In this next segment, we're excited to welcome Minnesota's own Lieutenant Governor, Peggy Flanagan. Finally, we're excited to welcome the President and CEO of Minnesota Hospital Association, Raul Coriani.
Hi, this is Lieutenant Governor Peggy Flanagan. I use she, her pronouns. Happy Pride Month, and thank you so much for participating in today's Beyond the Binary event. Our relatives, friends, and neighbors who are part of the LGBTQ+ community are an essential part of the vibrant fabric that makes up Minnesota during Pride Month and year-round. But we know that LGBTQ plus Minnesotans often experience barriers to their healthcare, housing, and other critical supports and services. The COVID-19 pandemic has also exposed and exacerbated inequities that existed for a long time, including in healthcare access. Whether you're a policymaker, a healthcare provider, a member of the community, or an ally or advocate, it's essential that we are honest about these disparities and barriers and work to undo them. Members of the LGBTQ plus community need and deserve healthcare services that are non-judgmental, safe, and comprehensive. Trans and non-binary Minnesotans need and deserve gender-affirming healthcare services. Black, Indigenous, and people of color who are members of the LGBTQ plus community deserve healthcare that treats their whole selves without bias, racism, or homophobia. We know that when biases like racism, homophobia, sexism, or xenophobia interact with systems like healthcare or government, we continue to produce worse outcomes for the most vulnerable among us. So the question before us is, how do we build a system and a state where LGBTQ plus Minnesotans can expect and receive high quality responsive healthcare? It means working toward ending practices that we know are harmful. Conversion therapy is wrong and it causes harm, especially to our young people who are discovering their identities. It means ensuring that Minnesotans can access affordable and comprehensive health care, from preserving the Affordable Care Act to recognizing that the right to marry the person you love can impact your access to health insurance and who can make decisions about your health. Health goes beyond what happens in clinics and checkups to when LGBTQ people feel accepted in their schools and homes and workplaces that supports mental, physical, and social well-being. That means trans students deserve the same opportunities in playing sports and accessing bathrooms. They deserve to be seen and heard and valued and protected in their schools. And we have to work through this on an individual level too. Move past Minnesota nice and confront the biases that we are raised and trained and worked in. It can be as simple as changing your language, saying person instead of man or woman when referring to a patient or their partners, and providing every patient with an opportunity to share their pronouns. Or as broad as recognizing how all of these issues are connected and fighting for systemic change that recognizes and affirms LGBTQ plus Minnesotans in every part of life, including the doctor's office. And I am so proud to be in this fight with all of you. I hope today's event is affirming, thought-provoking, and change-making. Thank you.
Good afternoon, everybody. I hope you had a fun time and an educational time this morning with all of the sessions. I know I did. Hope you are grabbing something tasty to eat and looking forward to the sessions this afternoon. I want to thank Jeremy Hansen-Willis and the Rainbow Health family for having me here to just share my perspective on the journey towards diversity, inclusion, and equity that we are all on and we all need to be. So I am Rahul Khurana. I have the incredible honor of serving as the president and chief executive officer of the Minnesota Hospital Association. The MHA is getting close to being 105 years old. And what we do is work with hospitals and healthcare systems across the entire state of Minnesota and sometimes the upper Midwest to continue to improve the care that we provide to our patients in our communities. And that includes all individuals, all communities, and all of the patients that we are privileged to serve. As caregivers, we want to make sure that every Minnesotan stays healthy and has access to high quality care when they need it. We want our communities to be safe places where residents can thrive and they gravitate towards those communities. We also believe that everyone should have the opportunity to reach their full health potential and that no one should be prevented from doing so because of social factors. We call these social influencers of health, and these are things like race, ethnicity, language. We worry quite a bit about structural racism. We also think about transportation inequities. We think about food insecurity, housing, and many other social and economic factors. And that's what we've been talking about and learning about today. Minnesota's hospitals and healthcare systems serve and are part of increasingly diverse communities. As healthcare providers and those working on behalf of patients and communities, we see every day how social factors have a strong impact on overall health. And we've discussed some of this data here today. We also know that COVID-19 has exacerbated some existing inequities. This includes LGBTQ plus individuals and families. We know that 1 in 5 LGBTQ plus adults in the US, or 22%, live in poverty compared to 16% poverty rate amongst their straight and cisgender counterparts. Also, LGBTQ patients are more than twice as likely as non-LGBTQ plus patients to have mental health disorders in their lifetimes, and are 2.5 times more likely to experience depression, anxiety, and substance misuse as compared to non-LGBTQ people. We also know that 1 in 5 LGBTQ adults have not seen a doctor when needed because they could not afford it, and 17% of these adults do not have any kind of health insurance coverage as compared to 12% of non-LGBTQ adults. Now, being a physician and a primary care provider who has practiced in Minnesota for close to 22 years, I take this to heart, and this really worries me personally. Healthcare is a part of an ecosystem that enables health, and building and maintaining trust in the healthcare system is extremely vital. So how do we ensure that? We have looked at some data in Minnesota, for example. In the past 12 months, 9% of respondents to a survey said that they postponed or did not get care because they feared they would be disrespected or mistreated as LGBTQ plus person. In the past 12 months, 10% of survey respondents had to teach their providers about LGBTQ people in order to get appropriate care. And 23% had done so at some point in their lifetime. Those numbers are just too high. We also know that we are hearing reports about caregivers sometimes using language which is not acceptable or does not lead to an inclusive caregiving experience. These negative interactions with the healthcare system are traumatic to all of us, and we need to change that. We need to create a healthcare system that is healing to all, and we are working very hard in Minnesota to do that. How do we do that? We do it through looking at our data. We look at charting a course towards a more inclusive healthcare system. We also think about patient and family engagement, and how can our patients come and help co-design a healthcare system which is more inclusive. The Minnesota Hospital Association and our hospitals and healthcare system members are on a relentless journey towards equity and inclusion. We are making progress, but we know we have a long journey ahead. All of the hospitals and healthcare systems across the state conduct community health needs assessments in partnership with their communities and all sectors of their community, so that they can respond to the unique needs of what their local communities need. We have been collecting over the last many years race, ethnicity, and language data, and we're looking at our quality metrics through that lens. We know we need to do more. We need to look at more inclusion data. We need to make sure that we are also looking at it through a LGBTQ lens. Finally, we're working on building a strong framework for federal guidance. In 2011, new and revised Joint Commission standards were published, and the Joint Commission is a body that accredits and reviews how hospitals and healthcare systems work and if they're serving their communities and patients appropriately. So the Joint Commission standards were published in 2011, which were new, that includes elements of performance prohibiting discrimination based on sexual orientation, gender identity, and gender expression, and ensuring access to a support person of the patient's choice. The Joint Commission is doing quite a bit of active work. It created a field guide for U.S. hospitals and healthcare systems and helping them create a more welcoming, safe, and inclusive environment that contributes to improving health equity and also health quality for lesbian, gay, bisexual, and transgender patients and their families. The Centers for Medicare and Medicaid Services, CMS, conditions of participation require policies prohibiting discrimination on the basis of race, color, religion, national origin, sex, which includes gender identity and sexual orientation. And that's where this partnership with Rainbow Health is so exciting to me and to the Minnesota Hospital Association. We have worked with you before. We hope to continue to work with you even more actively now to create educational material, to have you look at the policies that we have across the state so that we can continue on a relentless journey towards being more inclusive, towards being a healthcare system that works for everyone, that serves everyone and every single individual that we are here for. And finally, I would like to say that this is quite an honor for me to be here this afternoon to learn with you all and be able to share our data-led continuous improvement journey with you. We have not even reached the half mile post yet, and we need your support, your partnership, your help as we continue to make Minnesota the very best state in the country to not just receive care, but also to provide care. And that means a healthcare workforce that is also inclusive, that looks like the patients that we serve, that has diversity from all different angles, and our workforce is something that we care about as well. So thank you for having me here. Thank you for the amazing work that you do, and have a wonderful lunch, and let's get networking, enjoying some good food, and look forward to this afternoon's sessions. Thank you so much.
Thank you, Raul Coriani and Lieutenant Governor Peggy Flanagan, for joining us today. We are honored to have friends and allies working diligently to improve Minnesota for all of us. Now we're going to hear from our dear friend at Rainbow Health, who has experienced the impact that they are making firsthand.
Being a trans woman of color, the path has never been easy. I was born in Gary, Indiana, adopted by a family there. Never really part of the family. Thrown out at the age of 11 because of my female tendencies. My father threw me out at gunpoint. He was a functional alcoholic. He used to tell me quite often, to this very day I can still hear his voice in my head, I was not wanted in his house. The only reason I was there was because my mother wanted me. And that's the only reason that he brought me home from the orphanage. I never wanted you. And he made a point all through my 11 years at home. I never wanted you. It was a common thing, like brush your teeth or take out the dog. Yeah, never wanted you. You're not wanted here. I had my first sugar daddy at the age of 15. He was a 50 or 60-year-old man named Bay Ray. I'll never forget him. Very mean man. It was not easy, but there was power in numbers. There were about 6 or 7 of us that were on the streets of Gary at that time who were thrown out by our families. All young little black gay boys wanting to become, as I call it, not knowing how to. After being on the streets for quite a while, most of us slid into drugs or alcohol, just to be able to deal with the situation, to numb ourselves. I slipped into cocaine and liquor, and I ran my boyfriend's Mercedes under a semi-truck. The motor cooked my leg, literally, and that's why I've been clean and sober from the cocaine and alcohol ever since. Being a disabled woman? No problem. Being a disabled pre-op transgender, yes, I had a problem then. I did not have a path towards the final surgery. That was the biggie for me, was not being able to just be myself. Being a woman on a fixed income, I didn't have $60,000, $70,000. I was at the point of making a decision. If I did not have my surgery, by the age of 60, I was checking out because I was tired. I found out about Rainbow Health through E.J. Jack at the University of Minnesota when I had my first appointment with, now I consider him my savior, Dr. Kim. E.J. Jack connected me with Phil Duran, an attorney for Rainbow Health. Phil helped me navigate the insurance maze. He was able to get in there and argue and talk to these people and get them to stand by their policy, which was to cover the surgery. He took the complication away from me, and he handled all of that complication. Next thing I know, I'm getting a surgery date. For that person, a total stranger, to help you get to where you have been dying to be your entire life. That's what Phil did for me. Yeah, between him and Dr. Kim, they saved me. The day I woke up from my surgery, I felt something like a lift, and it's been that way ever since. It's been that way. Every morning I wake up, 2 years now, I'm giggling at some point because there's a movie, what was it, Death Becomes Her, I'm a girl. Yes, and I love it. Without Rainbow Health, I would not be sitting here now. I know the trans community would be at a big loss. We need people like that to fight with us. I never knew in a million years that this old girl from Gary, Indiana would be sitting here. Finally, 100%. I am a happy old disabled woman. Trust that. Believe it. All day long.
Thank you, Jacqueline, for sharing your powerful story with us. My name is Maren Levad, and I'm the Aging Services Advocate here at Rainbow Health. In my role working to help meet the needs of older adults, I've seen firsthand the work that has been happening and the work that still needs to be done to eliminate the barriers to healthcare that are all too common in our communities. Stories like Jacqueline's are at the center of Rainbow Health's work, but Rainbow Health doesn't take on cases like Jacqueline's just to help individuals. Our goal is to change the system to provide access to healthcare for all. We are made up of advocates, fighters, and change makers who want to make Minnesota a better place for everyone who has experienced injustice at the intersection of health status and identity. Coming together today is just one part of Rainbow Health's work that we do to move the community towards health equity and also raise the resources to make this work possible. Our work relies on the generosity of individuals and organizations who support our work and the continued legacies of the Minnesota AIDS Project, Rainbow Health Initiative, and Training to Serve. We urge you to make a gift to Rainbow Health in the amount that's meaningful to you by following the link on the screen and in the comments section to donate online. Visit bit.ly/2021 Transforming Care. That's bit.ly/2021 Transforming Care. Or you can text CARE 2021 to 44321. That's CARE 2021 to 44321. Thank you for your generosity today. It will take every one of us to transform care in Minnesota. And now, please welcome back our host, Miko Blaze.
Thank you, Maren. And thanks to all of you for joining us today for this special keynote. We hope you'll join us for 2 more educational sessions this afternoon led by Dr. Joe Pariser and Dr. Carrie Link, as well as Raquel Paulson and Cree Gordon. To learn more about all of today's sessions and attend this afternoon's, please visit bit.ly/2021 Transforming Care. Once again, thank you, and thank you to all of today's brilliant speakers, to all attendees, and to the supporters who make the work of Rainbow Health possible. Together, we will do what we gotta do to take care of you. This next song is called Lift You Up, which I wrote for this event. I hope you enjoy and sing along with us. Oh, yeah. We're gonna help you navigate, help you find a way through. We're gonna try to educate, deliver better care for you. Show you some compassion, break down barriers with you. We will do what we gotta do to take care of you. We'll meet you in the middle, our mission's to empower you. All the colors of the rainbow, we deserve to stand here too. And show you some compassion, break down barriers with you. We will do what we gotta do to take care of you. We will do what we gotta do to take care of you. We will do what we got to, do what we got to, do what we got to do. We will do what we got to, do what we got to, do what we got to do. Take action with compassion. Take action with compassion. Sing it with me. Take action with compassion. Take action with compassion. We're gonna lift you up. Say it with me now. We're gonna lift you up. Oh, we're gonna lift you up. Whoa, whoa. We're gonna lift you up. Oh, we're gonna lift you up. We're gonna lift you up. We're gonna lift you up. Gonna lift you up. Lift you up. Yeah, yeah.
unmute yourself.
And for those of you returning this morning's session or from the powerful keynote, welcome back. If you're just now joining us, note that the presentations recordings for all sessions will be available following the close of today's event. I want to take a moment to once again thank our sponsors, Allina Health, New Way, Ride at Home, Walmart Pharmacy, and Target. To achieve health equality here in Minnesota, it will take advocates in every sector. This afternoon, you'll continue to hear from a series of experts who will give us the knowledge and the tools to transform care for transgender, non-binary, and gender non-conforming Minnesotans. For detailed information about today's sessions, speakers, and more, please visit bit.ly/2021 Transforming Care. That's bit.ly/2021 Transforming Care. Each session will be a live webinar, and you'll have the opportunity to ask questions in our chat from our speakers. If you need assistance during the program, support from Rainbow Health will be available via chat, social media, or email at communityeducation@rainbowhealth.org. As a reminder, today we're going to talk about some important and difficult topics. Please know that you are not alone, and if you're in need of immediate support, please call the Trevor Lifeline at 1-866-488-7386 for ongoing care and support. Our behavioral health clinic is here for you. And now it's time to kick off our afternoon session. Up first, Dr. Carrie Link is an assistant professor at the University of Minnesota's Medical School, as well as faculty physician at Smiley's Clinic. Co-presenter Dr. Joe Pariser is the assistant professor of urology at the University of Minnesota, as well as the associate director of the Genital Urinary Reconstructive Surgery Fellowship. Together, they'll be detailing the surgical options for gender-affirming surgery.
Hi, everyone. I'm going to share my screen and introduce myself. So hopefully everyone can see my presentation. I just want to start by introducing myself. My name is Carrie Link, and I use she, her pronouns. And I want to thank Rainbow Health for having me. This is exciting. Happy Pride, everyone. I identify as a white, cis, queer academic, and have all of those lenses in front of me as I talk to you today. So I want to start off by just letting you know that I'm speaking with the hat on as the co-medical director for mHealth Fairview's comprehensive gender care group. And I do that work with Katie Spencer at the Institute for Sex and Gender Health. And I'm going to give you a quick overview kind of the program, and then Dr. Pariser will talk a little more specifically about some genital surgery options. And forgive my background, you know, this work from home business is interesting. So this is our mission and values. And then the bottom talks a little bit about our commitment. So really what we want our mission to be about is the comprehensive gender program, providing accessible, interdisciplinary, and integrative gender affirmative care across the lifespan. Historically, medical institutions have not provided this kind of care, and we want to be moving towards that. In our values, nothing about us without us is trying to describe integrating and centering trans and gender diverse voices in the decisions that we make, in our assessment of quality data, and in the feedback we get about the services that are needed or need to be improved. We really want to focus on health and well-being and understand that medical trauma is a very real thing that's happened, and historically we have not been very accountable to the trauma that we kind of induce on our community members, and want to use those lessons to create a trauma informed framework for how we move forward with gender affirmative care at the university. Of course, all of this requires interdisciplinary collaboration with many different groups of people, and there will be some slides later that address that. You know, I don't identify as trans or gender non-conforming or gender non-binary. However, my vision is that someone will hold this position after me that does, because I think we need to continue to move that nothing about us without us. Our vision and commitment is really that we want to serve community and achieving this through a few particular steps. We have to translate our values into practice, and that is extremely hard, and we are certainly not there yet, but we're making steps in that direction. We want to conduct research, translate that research, and use that to define how we provide compassionate care that's culturally appropriate. We want to use our empiric-based research to define these quality metrics that we can use throughout the system to address health disparities. We want to train all healthcare providers within the system, educate them on gender issues and gender health, and advocate for equitable care. Now, if you have questions, go ahead and put them in the chat, but I'm sharing my screen, so one of the folks from Rainbow Health may just pop up and share what some of the questions. Sorry. So I wanted to share a little bit of the history of gender care. And that history is long, but not particularly active during some of the early period at the university, just because it was really all done, like all of the care and the research has really been performed at the Program in Human Sexuality, which just was named an institute. So now they're called the Institute for Gender and Sexual Health. So that was really since the 70s. They've had a 50-year history and really just celebrated their 50th anniversary, actually. So that included, the early genital surgeries that were done in the 70s. And then we have this large gap in time where we didn't have a lot of services that were being offered. And into the early 2000s, there was some of the plastic surgeons were doing top surgery on a little bit of a larger scale. In 2013, I think is really when my clinic, I'm a family physician, I work at Smiley's Family Medicine, started to make some significant changes based on feedback from the community and a needs assessment to start rolling out a program for providing hormones on a larger scale. In 2017, we started bottom surgery, and then we started to introduce a few other elements, like the care coordinator position was introduced, and that person is extremely central to our entire program. We had kind of a restructuring in 2020, and now we're trying to define exactly what are the elements needed to create the infrastructure to support what the community needs are. And we're going to do this in partnership with the Fairview Hope Commission, which is this multi-year investment to change around more equitable outcomes. So that's just a recent event. I keep going forward too many slides, sorry. So when we think about comprehensive gender care at mHealth Fairview, what we're really thinking about is decentralizing care throughout all these different departments, disciplines, clinics. So we have clinics all over, right? But the idea is that we are really centering our care around a central patient navigator that is helping folks to navigate all of the different places that they may end up at the university or that's affiliated with it. So we offer a ton of different specialty services that are related to gender. Primary care, that's what I do, which and hormone therapy can be within primary care or potentially endocrine. There are other places that you can potentially get hormone therapy. All the medical specialties or surgical subspecialties, which includes both urology and plastics. You can read the list. I wanted to call out our sort of specialized surgical care, what this includes and what we offer, which is breast augmentation, top surgery. Lower surgeries include phalloplasties, vaginoplasties, which is either full depth or minimal, orchiectomies, and then of course revision surgeries by people who are trained to do reconstructive surgeries, and then facial feminization is a relatively new offering. So using this kind of idea of all these different spokes in the wheel in a central hub, we really require a clinical and support staff for this. So we have a full-time transgender coordinator and who has a social work background, EJ Jack. And we are all very sad to announce that June 18th will be his last day working with us before he moves on. So we're hiring for a replacement position for that. And then we have a full-time intake and referral coordinator, Cadel, and they're touching base with people as they come into the system, either via MyChart or by phone or by referral from their provider. We've created the medical director's position so that we can try to help advocate within the system for some of the services that are needed. And then we have a variety of MDs, DOs, APPs, RNs that are providing gender affirmative care throughout the system. And I just wanted to call out this contact phone number is the direct dial number into CGC. And then your other option is to MyChart through your provider if you have access to MyChart. But external to the system, if you don't have MyChart, you can get through on that phone number. 676-4227. So one of the things that in the redesign in 2020 that we did was really identify what would be the governing structure of comprehensive gender care and created a steering committee, which has a number of members across disciplines. And then there's 3 subsets of that, the clinical and quality work group, the community advisory group, which is also called a patient family and advisory council or a PFAC, and the operations work group. And these have different jobs. The clinical and quality is really a group of providers that are trying to identify what are best practices and get those to spread, really try to identify what are the main priority patient issues, like our wait list, for example, right now, and to try to gather that research and really make that accessible. And the community advisory group is where we have good representation. That's run by the CGC manager, and really is identifying what patients think that we need to prioritize and trying to bring trans and gender diverse voices to the table. And then our work group is like the day-to-day operations of how we run our clinics and surgeries, get equipment, staffing, training, etc. So in a truly comprehensive program, there are all of these services being offered, and some programs across the country are more surgery-focused programs that have different particular design elements. And mHealth Fairview's current state is that we have some surgical medical services and we have some gaps here, right? So we don't have a good community outreach or liaison person. We are lacking some of these other services. So that's a big piece of what the medical directors are trying to do in advocating for these services. So we have some improvements that we definitely need to be making. And I think that it can be summarized by saying that we have to commit to building a true comprehensive gender program, and that we can't have gaps in care, and that we have traditionally left people in the wind in the medical industrial complex in the care of diversely gendered people. So we're really asking mHealth Fairview to increase their resources for the services that are needed in our community. So like, for example, we have specialty services personnel. There's specific needs around that. Many of you probably have been aware that Dr. Nick Kim is leaving university, and we have created a posting for a new plastic surgeon because plastic surgeons in particular have certain skills that are required for some surgical services. But Dr. Joseph Pariser, who is on this Zoom and you'll be talking to momentarily, is going to be continuing doing lower surgeries as he has been for some time actually. And that'll be continuing so that we can keep working through our surgical list. And then we're working on our priorities right now. We're hiring a social worker, a dedicated prior authorization kind of financial counselor person, and a program manager. None of those have yet been posted, but that's in the works right now. And I want to be relatively transparent that we have a long wait list. That was complicated by COVID when surgery was shut down. It was also complicated by our inability to do hair removal. I don't know if you know, but hair removal is a particular procedure that requires that N95 mask that was so hard to get early in the pandemic in particular, and it can only have a single use. So a lot of us were reusing our N95s with a special washing technique for COVID, but you can't do that because of HPV particles that are associated with hair follicles. So a little fun fact that I had to learn and understand the dermatology research to be able to translate to patients why it was unsafe to do it. And we finally got that going. Our dermatologists have been really great advocates for restarting the program, and they're working their way through the list, and they think they'll be through it by the end of summer. So that's a necessity for kind of advancing our lower surgeries, for example, the hair removal program. So we do have a long wait list, and I think that we, especially as clinicians in power positions, have to advocate for moving that along so that the services continue to be offered in a timely fashion to our community members. And then I want to make a note about outcomes, because I definitely think that there are items in which we can improve kind of our gender affirming care across our system, but there's also going to be for each individual sort of pros and cons of services that they may choose to pursue. And I think each person has to weigh that for location and surgeon and type of procedure. But really, feedback is super essential to us, because we have this goal of moving our system from being sort of gender aware with, individual pockets of people who are quite competent or maybe even doing gender affirming care. So gender aware, moving the needle to become gender competent, but keep moving the needle to become actually gender affirming. And I don't see a lot of systems that I can truly, honestly describe as gender affirmative, but that's my goal for the system. So I think the feedback from y'all is critical. Your post-visit surveys are useful. The Patient Family and Advisory Council is another way that we get feedback in a formal manner. And then I also wanted to put my email on here just because it's linkx010@umn.edu for any of those who might have visual impairments. I just want to make sure that you get that, because I can help direct you or help navigate the system if there are, you're having issues. So you can definitely use me as a resource. And then I just want to really give out a big, enormous shout to EJ Jack, who, despite the fact that he's leaving, has left a bit of a legacy. He is a great program developer and has done this in different places in the country, developed programs, and it was a particular skill set that he brought to us. And we were absolutely blessed to have him for these last 3.5, 4 years. And I think this picture also shows some of our other team members, and there's Dr. Pariser and Katie Spencer, Lisa Butcher over at the in our speech and language department. So I just wanted to take an opportunity to give a shout out to him. So thanks, and I'll be happy to take any questions, or we can save them for the end. I'm gonna stop sharing here.
Carrie, is that my cue?
Well, that would have been nice of me to actually say, yeah, it's your turn. I'm sorry about that, Dr. Pariser. Yeah. I will now allow Dr. Pariser to complete his presentation.
Okay, one moment. Okay, can everyone see that?
Yes.
And you can hear me okay? Okay, nice to meet you. This is a real honor to be able to speak today. My name is Joe Pariser. I'm a urologist at the University of Minnesota, part of the CGC that Carrie talked about. Since Dr. Kim left, I'm the gender affirming genital surgeon. For 3 years, we did all the surgeries together, pretty much every step of the way. And when he left, I felt comfortable to continue to offer it. We just finished a vaginoplasty this morning, so I'm glad I was able to make it to this talk. Disclosure, I am a consultant for a device company. So the goals of this talk are to describe surgical options for feminizing lower surgery, some care pathways we offer, and just review some complications, because these are complicated surgeries. And then I'm going to describe some masculizing gender affirming options. And similarly, I'll talk about care pathways and complications. I will give a disclaimer. Some of the pictures are a little graphic. So if you don't want to see surgery pictures or intraoperative pictures, close your eyes for a while or look away. And sometimes I use anatomic terms. I know people have terms they prefer for their own bodies, but I'm trying this mostly for clarity. So just to review surgery options for feminizing surgery, there are breast augmentations for top surgery. And lower surgery is orchiectomy, vaginoplasty, or some people call vulvoplasty if it's minimal depth. There's also labiaplasties, and there's also craniofacial, facial feminization surgery. For masculizing surgery, there's mastectomy, and then hysterectomy, which the gynecologists used to perform, and then vaginectomy, metoidioplasty, and phalloplasty are options. We follow the WPATH standard of care guidelines. For top surgery, that's 1 liter of support. You don't need to have a social transition. You don't need to have hormone therapy, but at least 1 year of estrogen is recommended. For lower surgery, so that's most of my surgery, all of my surgeries, I require 2 letters of support, 12 months of social transition required for any bottom surgery, and social transition is not explicitly required for hysterectomy or orchiectomy, and 12 months of hormone therapy is required for prior to any lower surgery, unless there's a medical contraindication, for example, to estrogen. So I'll review orchiectomy real quick. I see you in clinic. I ensure you meet the WPATH criteria. We asked for prior authorization. I talked to you about the surgery. For orchiectomy, I prefer a midline incision. That's to reduce any scars that will be visible if you choose to have a future vaginoplasty. Some people do put them in the lower groin, but those scars would be across a future vaginoplasty site. So better, and it's a little more difficult to do midline, but that's what we prefer. We use numbing medication to make it more comfortable. You want to take the stump because some patients do report dysphoria with stumps. So my patients, I really try hard not to have them, and I do have some patients come to me saying they had it done elsewhere and they have stumps. Now, there's always a question: if you want a vaginoplasty in the future, can you do it during the vaginoplasty, or should you have a pre-op orchiectomy? I let patients decide. The waiting list for orchiectomy is much shorter because it's a very quick procedure, and it does shorten the vaginoplasty procedure in the future, and it does allow you to stop spironolactone or finasteride if you're on those medications and you stop those side effects. So I don't feel strongly. You can certainly do it during a vaginoplasty, or you could do it beforehand. I would say half the patients choose one of the 2 routes. The complications of orchiectomy is mostly bleeding or swelling. If it stays in your body, you'll get some swelling of the area. If it comes out of your body, that's okay, but it does make a little bit of a mess, and patients do get worried. But it usually resolves on its own unless it's severe. So that's it for orchiectomy. I'm happy to answer questions at the end about it if you have any. In terms of vaginoplasty, which we continue to offer, there's full depth, which means all the parts of the vagina and a canal. Or you can have a limited depth or minimal depth vaginoplasty. In the literature, some people call this a vulvoplasty. That's all the same parts externally. It looks the same, There's still a clitoris, urethra, labia formed, introitus, but the depth is only an inch or two. So you would not be able to, for example, have receptive intercourse. Patients, so in a big series from Oregon, out of 8% of their patients choose to have minimal depth, but the satisfaction rate is very high. So I let patients decide, and if that's what they want to do, literature would show that patients are very satisfied. Now, in terms of full depth, there are different ways to make the canal. You can use the standard way that most surgeons do around the world in the country is penile inversion and scrotal skin graft. So the skin on the shaft is inverted, and then to get the full depth, you need to add a scrotal skin graft. That's one of the reasons why we do hair removal. Alternative approaches is to add peritoneal flaps, which we do offer at times, which is aligning of the inside of the body and a newer technique. And then some patients have an intestinal vaginoplasty, so that's not standard. Here's an example of a vaginoplasty pre-op and post-op picture of penile inversion vaginoplasty. The steps of vaginoplasty, I'll quickly review. I know this is not a surgeon's talk, but I just want to review. It is a challenging case with a lot of steps. So you disassemble the structure, you remove the erectile body, you form a clitoris, you form a urethra, you build a canal if that's the choice of vaginoplasty, and then you line the canal and you close the surgical sites. This is a little bit graphic, but the structures are separated, and then the structures that you don't want anymore are discarded, and some of the structures, for example, the urethra is cut short so you can sit in the toilet, pee in the toilet. The clitoris is formed using these incisions. The urethra is cut low so it doesn't stick out of the body, but rather directly into the toilet in a seated position. And then the canal dissection, we transitioned earlier this year to a robotic approach, which I find to be much quicker, safer, and better in the long term. And in our hands, I personally feel that our robotic dissection with someone working from below and above allows us to create a much larger cavity than before. One of the biggest complications of surgery is stenosis, and the robotic dissection is really nice. I sometimes tell patients, it's kind of like if you had to dig a hole in a cave to find gold, and you only had one way to dissect, but using a robotic approach, you can come from below and above and meet in the middle. And then this is the lining of the canal. This is from a publication from Oregon, where the native skin is here, and then the scrotal skin, which had prior hair removal, is here. And so that's the apex of the vagina, or the upper 2/3 of the vagina. The labiaplasty, we do form a clitoral hood from the skin just behind the clitoris, and the labia majora are formed by the lateral genital tissue. Down in the corners are the sites of the highest areas of wound dehiscence. In our hands, we leave a stent for 5 days. We leave a catheter to drain the bladder, some drains, and then we take all this out on post-op day 5. And we start dilating a couple days after discharge. Dilation is critical for patients undergoing vaginoplasty with a canal. Dilation is 3 times a day for 3 months. Each dilation, you put the dilator into its maximum and you leave it there for 15 minutes. You do that for 3 months, and then you can slowly de-escalate the dilation regimen to 2 times a day until 12 months and once a day indefinitely. Eventually, some people can say every day, every other day, but if you stop dilating, the canal shuts down and there will not be a canal anymore. It's very hard to get back. Complications of vaginoplasty involve blood clots, which can be deadly. They're very uncommon though. In big series of 300 and 230 patients, 0 or 1% have blood clots. Practice patterns vary. In our hands, we stop estradiol 2 weeks before and after surgery, and we do give some prophylactic blood thinner the morning of surgery. We also encourage patients the day after surgery to start walking, which does prevent blood clots. Complications of vaginoplasty. The most scary complications involve making the canal, which the worst feared complication is rectourethral injury. And in the largest series from Amsterdam, 475 patients, they had 2% of patients have a rectal injury. Now, some of those were identified at the time of surgery and closed, and 1 out of 200 patients, or 0.6%, had a rectovaginal fistula, meaning stool coming out of their new vagina. Other series are in that range as well. Urethral injury is less frequently reported, but in a similar couple percent chance. In general, urethral injuries are not as big of a deal and can be fixed at the time. But if they're very high, meaning deep in the canal, they can lead to incontinence. Wound complications are common in these series. A quarter or a third of patients have them, especially the full depths, because the dilation is stretching that skin that is fresh and moved higher up on the body down low. Now, most of these wounds heal on their own without surgical intervention, but sometimes if they heal asymmetrically or with poor cosmesis, then they could use a revision. Meatal stenosis is closure of the urethra at where it's brought to the skin. And the way we do it is very uncommon, but in the old days, you would see this pinhole urethra that people urinate from. And in these series where they did it using old techniques, they would have it in up to a third of patients. Now, vaginal stenosis, which is a long-term complication, meaning the vagina closes up either with width or depth, happens in these series about 10% of patients. But we know that patients, after a year or two, some of them move, some of them stop following up with their primary surgeon. So this is probably underreported. Most commonly, it's related to stopping dilation, which, for example, some of my older patients do. But sometimes it's an early complication of wound infection, where the skin of the canal that's lining the canal gets infected, and the way it scars, the dilation becomes difficult, and then you lose your either depth or width. There's been systematic reviews of large series of vaginoplasties. And so here's a bunch of studies, and they correlate all the data. And what you find is most of the studies are retrospective, which means they're not following the patient's prospective, they're just doing chart review afterwards. Most of the studies just review the chart and don't actually diagram or assess the vaginal anatomy. Complication rates vary widely. Like I said earlier, some of the complication rates for urethral complications are 1%, some are 40%. And that may be related to technique, or it might be related to capture. Sadly, sexual function is not reported in all studies, just under half of studies, and even patient satisfaction, something pretty easy to ask. And in my opinion, one of the most important things is the patient happy with the outcome, is only measured in half of the studies. And then quality of life assessment, which we have tools, validated tools to ask about quality of life, is very rare. And follow up very significantly. Some patients, 3 months in, they're sent off, and some patients are followed annually for decades. Revision labiaplasty is something we offer, especially if the labia heal asymmetrically, or you want a little more lenticular or lens-shaped labia towards the top near the clitoris. There's a very high satisfaction rate. There's a patient who came to us with very asymmetric healing, and a little bit of complicated surgery. By the end, we can give her a really nice outcome. There's a newer approach called robotic peritoneal vaginoplasty, which can be done either during a primary vaginoplasty, meaning the first time you're having it done, or in a revision surgery, which is more commonly how I offer it. It's a very uncommonly done surgery. It was invented in New York by a close friend of mine just a few years ago. And I adapted it myself to bring it to Minnesota. So this is, in my opinion, the best option for patients who have good external features, but they're really struggling with their canal depth. And before this, the best option would be to just go down below and try to dissect. But that area was previously dissected and scarred and very difficult. So the way we offer it, we go robotically through your abdomen with small, tiny 8mm incisions, and we go find your canal, which in this diagram is this blue and green and C. And then we open it, and then we add the yellow, which is the peritoneal lining. And on the right, you can see the canal is this where the packing is, and the canal is sometimes 4 or 5 inches longer than it used to be. We've done a a dozen or 2 dozen of these cases, and the patients are really happy with their depth and width. And I'm really satisfied with the procedure, and I'm glad to have brought it to Minnesota. In terms of vaginoplasty, patients, just things I've learned and are described in literature, is patients do not like orchiectomy stumps. Patients can, have issues with their clitoral size. Sometimes if it's too big, it looks a little phallic, dysphoric. Sometimes it's too small, it can be, and in the old days, they used to just remove it. It can be too small, which makes it hard to find. It can be buried under some skin. Some surgeons leave too much erectile bodies, which can be dysphoric when you're aroused, and lift the, almost like a mini erection. And then the location of the urethra is a little touchy. You want it nice at the midline, and you want it low enough that it points right in the toilet. If it's too high, it shoots over the toilet seat when you're sitting. And if it's too low, it goes into your vagina. It's not a huge deal, but there can be some vaginal voiding or spraying. Asymmetric healing is difficult to plan for. We try to make everything as symmetric as possible in the operating room. And then canal stenosis, which we talked about. So that's it for feminizing surgery. I think we have time to talk about masculinizing surgery. So the goals are aesthetic masculine appearance, voiding while standing for most patients, erogenous sensation, and erectile function. Again, not for all patients, but some patients. There's a bunch of different phalloplasty techniques. There's one stage technique and multiple stage techniques. One stage technique means creation of the neophallus, transferring that to the genital region, removing the vagina, creating the urethra to the tip of the penis, and building a scrotum. Multiple stage breaks this into different stages to separate complications and make the recovery more straightforward. There are pluses and minuses of each. I don't personally count prosthesis as a stage because it's not required. It's the patient's wishes. Some people would call that another stage. So one stage really is 2 stages, and 2 stages really 3 stages. Most people build these with a tube-in-tube design using a single piece of tissue, but you can use 2 different pieces of tissue, for example, one with the urethra and one with the shaft of the penis. The most common is a radial forearm flap, which I'll show you pictures of. Other centers do offer latissimus dorsi, which are from the back. For example, that's the preferred method in Serbia. ALT or thigh flaps are commonly offered. There's also groin flaps and lower abdominal flaps, which are described, and we've done some of these. So the most common is a tube-in-tube radial forearm. Here's a version of an ALT. One of the downsides of an ALT or thigh flap is they're often thicker. You can pinch your own thigh and realize that there's a thicker amount of tissue you can get in your hand compared to your arm. Your arm is very thin, and the penis is often very thin. So you need to roll it twice. So you can imagine rolling a very thick newspaper twice. That's how you get a very thick ALT. And we sometimes do a composite flap with ALT and groin. Another option for surgery, this is from Serbia, is a metoidioplasty. And you basically free up the organ and then roll the urethra to the tip. And you can achieve the goal of voiding while standing. There's good sensation. You can build a scrotum. In terms of putting a prosthesis in penetrative intercourse, that would be a challenge. But some patients choose to have metoidioplasty. I hope to offer this sometime in the near future. So the steps of phalloplasty, which I'll briefly review, is flap, harvest, and transfer, nerve dissection and nerve connections, vaginectomy, urethroplasty, scrotoplasty, and glandoplasty. So the flap, this is a little bit graphic, is most commonly dissected from an arm. You basically build the penis on an arm, which is a wacky picture. You can review it in this paper if you ever want to look it up yourself. This is how you would harvest a leg. You can see them rolling the urethra, and then around it will be a shaft. Now the question is, should we stage? The single stage has fewer surgeries. That's for sure. You're signing people up for 2 stages. And if you stage it, you can do the metoidioplasty first, which is basically the vaginectomy, scrotoplasty, and urethral lengthening. The advantage of this is the urethra is healed prior to flap surgery, and you can certainly stop. So if you've had a prior metoidioplasty, you're still a candidate for phalloplasty. They've already done some of the steps. Flap first is how we were offering, which is the other way, meaning the stage 1 is flap transfer. So the arm or thigh is harvested and moved to the genital region, basically on the pubic symphysis. And then you heal up for 4 to 5 months. And then on the second stage, you do vaginectomy, urethroplasty, scrotoplasty. You can often do glandoplasty during this time. This really separates the surgery out, the plastic surgery complications, which are the flap transfer and keeping the new neophallus alive, from the urethral complications like strictures and fistulas. We know from experience that when the flap or blood supply suffers, you can often get a cascading effect of complications, and it becomes hard to manage. For example, if you get a blood clot in your flap, you would want to give the patient blood thinners. But if you just did a vaginectomy, you could bleed into the vaginal space. So you can see how one complication might cause another complication. So this is the way we switched. We started doing one stage and we switched. And I have to tell you, I think the staged approach is really nice. It makes for more streamlined patient recovery, fewer ER visits, fewer disaster complications. And a lot of the major centers around the country have moved to this. With Dr. Kim gone, we're seeking a surgeon to help me with stage 1. I still offer stage 2 for all the patients we've signed up, as that is basically a urologic surgery, but I'm not an arm surgeon. The nerve dissection, we dissect the native nerves of the body, which you can see here, and we hook that up to whatever arm or thigh flap comes down to give you erogenous sensation. We also hook it up to the groin nerves to give you tactile sensation. Nerve sensation can take up to a year to come back. We usually do 2 nerves like I talked about. This is the appearance of a first stage phalloplasty after flap transfer. So the natal organs down here are mostly still in situ. This catheter does exit down in the genital region, but that's not connected to the native urethra yet. Vaginectomy can be performed from below, meaning between the legs, or robotically. I prefer robotic as it's much more thorough and easy to do. Some people just vaporize the vagina, and that's been demonstrated to be safe, but some patients with vaporization have complications because that space fills back up and basically regrows. And I do have some patients I have to excise later from other surgeons, so I don't do that technique. Like I said, I like the robotic approach, especially if doing it staged. Then you do the urethroplasty. The urethroplasty is rolled to the tip. So from the native urethra up to the part of the urethra that's going to come out of the tip of the penis. This is from a paper where they were doing a second stage. So you can see the yellow catheter in the top left is coming out of the tip of the penis and then exits in the genital region and then goes into the native urethra. And then these are all dissected apart. The urethra is closed, so it's a continuous tube from the bladder to the tip of the penis. And then the labia are freed up and rolled into a scrotum, which looks very nice in the bottom right. There's different ways to do scrotoplasty. I also do it very similar to this. And you make a scrotoplasty. People like a large scrotum. They like it just under the penis, and they like it anterior, meaning not between the legs, but in front of the legs, especially when you're standing. Otherwise, you sit in your scrotum, and it's pretty annoying. And then glandoplasty. Glandoplasty can be sometimes done during the arm surgery, though never done during the leg surgery. Or you can wait till later. The longer you wait, the better the blood supply is. The most common technique is a Norfolk technique. And basically the head of the penis is cut and marked and then rolled to give you that nice coronal ridge. And then you fill the defect in with skin graft. A modified technique, which we brought back from Belgium, is skin grafts both in the flat defect and also making a turn. We find this makes a little better definition. One of the problems with glandoplasty is that people, it looks great in the operating room, but once they heal, that gland gets pretty flat again. So here's a picture, demonstration from the paper about Belgian glandoplasty. Looks very nice at the end. Here's another patient, and that's a little more healed. And then 7 months post-op, it sort of looks like that with a nice definition. It's pretty easy outpatient surgery if if you're having that alone. Phalloplasty complications involve blood clots, wound problems, bleeding. Flap loss is the really devastating one, meaning you move the arm or thigh tissue, you do all that work and you move it over, and sometime either in the operating room or within the first week, it loses its blood supply and you lose the flap. It's extremely low in all the series, meaning less than 5%. Some techniques it is higher. In some patients, you know, if a very watchful eye plastic surgeon can tell that things are wrong and take the patient back for surgery for a revision. That does sometimes happen. Urethral complications are the ones that are more common. Up to a third of patients have urethral fistula, which is a leak, or a stricture, which is a blockage. That can happen early after surgery or in the first few months. Using our staged approach, anecdotally at least, our fistula and stricture rate went down dramatically from this approach. So another reason I stopped dealing with so many complications when I switched to a stage approach, and my patients were happier and happy to not go down this road of urethral complication and urethral revisions. These are some examples of complications. Urethrogram is where we fill the bladder or fill the urethra with contrast and patients pee. And so here's a blockage of the urethra in the neophallus. And here's an example of a fistula in the neophallus. It's supposed to be a nice clean tube and there's like a side leak. Some of these leaks heal on their own. The strictures tend to need surgery. There are been systematic reviews in phalloplasty, but as you know, research for gender affirming surgery is poor. And this is all the outcomes they could think of. And you see there's a lot of NRs, meaning not recorded, meaning whoever wrote that study didn't look at that thing. And for example, tactile cessation or erogenous cessation, lots of surgery, lots of outcome measures, lots of papers don't even mention this in their study. Urethral complication rates vary widely from 20 to 80%. So I tell patients 30, 40%. And the complications per patient, meaning if you get a wound complication and a urethral complication, that's 2 complications. That would be 200%. The complications per patient is 40 to 127%. Donor site complications, meaning where you took the arm tissue, vary greatly. I think it really depends on how tight you are with calling a complication, meaning a little bit of hand mobility decrease. Is that a complication? It's hard to know. I think the more strict you are, the higher number you will get. Urethral complications, just notably, are very hard to fix. The best paper is out of Belgium. They did 118 urethral repairs in patients with radioform preflaps. And the success rates were not good, even in the center of excellence, 25 to 50% using a variety of different techniques. Different things that patients, I hear reasons for displeasure or revisions. Some patients go down this road of urethral complications. And we know just from that last slide that the urethral complications are not easily fixed. In a cisgender male urethra, our success rate in urethroplasty is 80, 90% for urethroplasty. But as you see from that other slide, in a neophallus, they are sometimes 25, 30, 40%. So patients are unhappy if they become repeated urethral surgery patients. Scrotum too small is challenging to fix. Phallus too wide, which is not physiologic and capable of having penetrative intercourse, is tough. You can debulk them. And then patients who have inadequate hair removal who end up with hairy urethras, that can be a real challenge with infections and retention and blockages. You can pluck them out, but it's very hard to do permanent hair removal in the urethra after it's in. And then lastly, I don't have time to go into prosthetics in detail. I offer both inflatable penile prosthesis and testicular prosthesis after phalloplasty. Inflatable penile prosthesis is not customized for in the neophallus. We are basically rigging the coloplast device using an ongoing evolution of techniques to connect the back of the device to the pubic bone, and then center the device and to allow you to inflate and deflate and give yourself some rigidity to allow penetrative intercourse. There is a device overseas that was designed for patients with the neophallus, but it's not much better, and there are a lot of problems with that device too. It is not here in America for use. Testicular prostheses, there are saline and silicone prostheses. I used also the Coloplast saline prosthetics. They come in different sizes. You fill them to the appropriate texture to make them a little bit squishy, like most testicles, and you place them. There are a lot of complaints with migration, and people get annoyed with the testicular prosthesis if they're between the legs too far, or they move around, or they ride around. They're hard to get just right. It's not a major surgery, but it is annoying for some patients. So the take-home points is the care of transgender patients and gender affirmation surgery is multidisciplinary. There's a high complication rate, so I always spend extra time discussing similar things like I talked to you all in this discussion, and I try to spend time and really counsel patients well and answer all questions. There are constant and unique surgical challenges. We're a real center for revision surgery, so a high percentage of my patients, probably compared to most, have had their surgery elsewhere and come to me looking for options. And some of the options I spoke about in our talk today, for example, I'll be the, I'm the only surgeon in the state offering. So I really try to push myself to give patients in our area, in region and nationally, all the options that cutting edge modern surgery offer. I'm not someone who sits and says, well, that's the way I learned it. I don't know, there's a guy over there who does it. I'm not gonna learn that, or I'm not gonna offer that because that's not the way I do it. I really try to give you state-of-the-art techniques. If you're gonna have gender affirmation surgery, even something as simple as an orchiectomy, which is commonly done by most urologists, there are nuances in orchiectomy. For example, the stumps and where you make the incisions and things like that, and the hormone management. So I strongly recommend you go to a surgeon who does gender affirmation for a significant portion of their practice, not someone who, quote, dabbles in gender affirming surgery. Here's our building where we see patients in preoperative surgery consult and do outpatient surgery. And here are my references. Thank you.
Thank you so much. And if both you, Dr. Purser, and Dr. Link would just pop back on. I apologize if you hear my dogs barking in the background. I did see Dr. Link kind of responding to a question about helping specifically like mental care providers help their patients navigate surgery and what they might need for that. And just if you have any advice for other care providers providing that bridge for patients.
Yeah, Dr. Pariser, do you have thoughts on other surgeons' websites that give like good explanations or good pictures, good descriptions?
I think there are some well done that just give you the basics. I mean, some of the things, for example, I talked about in my slides, just the basics of surgeries that are offered in picture form. We do have a picture book if you come to clinic. We don't have that on our website. I think it's good to educate patients and have them know their options. I'm always surprised, but I guess not surprised that patients come to me and, I mean, patients always do a lot of research. That is not surprising, but to not understand even their own options, for example, for vaginoplasty complications or what a peritoneal vaginoplasty is. But I do like the websites in general.
Okay.
In terms of the mental health, your actual question was about how to sort of connect primary care and mental health providers. Is that right?
I think the question in the Q&A was about people who were like not ready to see the surgeon yet, but wanted to kind of gather more information. But I think highlighting that relationship with mental health and primary care is important because we can kind of help folks understand what their options are and maybe what would be more or less accessible to them based on their more individualized needs and or risk factors. It's
yeah,
also,
and I think just like going to a surgeon who does gender affirmation all the time, going to a provider who does gender affirming care all the time. I mean, you can ask Carrie, she knows the options, you know, but if you're, I mean, some people have difficult access and I understand that, but if you, yeah, so, I mean, there's a lot of publicly available resources and also seeking out people who do this for a living.
I also want to say that, I think one of the things that's really intimidating is that our medical language is so technical, and a lot of the resources haven't really been accessible to patients. And now there's more and more resources that are being made available online. So I think everybody can like maybe take a deep breath after seeing all of Dr. Pariser's, intense pictures, and just recognize that what we're talking about is not maybe the thing that most people are used to talking about looking at. And so people might be a little traumatized in the moment in front of a provider and not be able to find the right words to put together their questions. But that's why an ongoing relationship is important. You can follow up, you can my chart message, you can bring a person or an advocate with you that says, I remember you had this question. So I think that relationship with someone who understands gender-related surgeries is super important. I know that all of our sex therapists have been extremely helpful to our patients in providing some of that kind of support along the way. Do folks have questions?
If there aren't more, we do only have a couple of minutes, so I would invite everyone to take a nice deep cleansing breath. Sometimes it's tough to absorb a lot of technical information that we're not used to, and I'm really glad that folks had the opportunity to do that today. It's stuff that's hard to get our hands on, and we really appreciate both of you making sure that folks can have an informed decision as they go forward in their surgical paths. So thank you.
If you want to seek care with us, the Carrie's number is the right one, and we'll plug you in and start you off in the process and make sure of all the criteria and talk to you about surgery options and get the ball rolling. So thank you again for the opportunity to speak. I have to get back to surgery after this.
Thank you so much. Thank you for your time, both of you. Have a great rest of your day.
Thank you.
For everybody else, we've got just about 5 minutes until the next session. We'll have Raquel and Cree here from the Youth and AIDS Project. So stick around. We'll see you in just a few minutes. Thank you.
Welcome back to our final session of the day. If you're just now joining us, presentation recordings for all sessions will be available following the close of today's event. If you're seeking continuing medical education credits for these sessions, please email community.education@rainbowhealth.org with the titles of the sessions you attended to receive the application survey. Here to close out this day full of education and community connection are longtime friends of Rainbow Health lead medical case manager at the Youth and AIDS Project, Raquel Paulson, and HIV prevention coordinator at the Youth and AIDS Project, Cree Gordon. They'll be detailing the importance of accurate data collection when working with folks who are trans or non-binary and living with HIV.
Hi, everyone. My name is Cree Gordon. And yes, I work with Raquel at the Youth and AIDS Project. And I figured we would go ahead and give a fuller introduction about who we are and what brought us to the work and why the data for trans folks is important to us. I'll talk a little bit about how HIV is affecting or has affected trans folks and what that looks like in the numbers. And then we will discuss what we did in collaboration with our friends at the Minnesota Council for HIV Care and Prevention and MDH to better inform us on the data or better include us in the data around HIV. So I'll go first in giving a little more of a formal introduction. So just so you know who we are and sort of what brought us here. So again, I'm Cree. I was born in a small town in rural Louisiana, population 1,500. So we're a little blip on a map. But I spent the majority of my adult life in Oregon before moving here to the Twin Cities in 2017 to do HIV work. What brought me to HIV work was what got me to Oregon was that I was a homeless youth and sex worker, and someone suggested that I go to Oregon because there were many resources for runaway and homeless youth. And so I went there and I took the only HIV test that I would ever need because the first one I took came back positive. And so as someone who is Black, who identifies as non-binary, I thought it was important 16 years ago when I was diagnosed to educate myself on HIV, how it's going to affect me. And then I realized that not everybody had this education. So I made it my mission to become an educator and an advocate, particularly for Black folks, trans and non-binary folks, and young people as related to sexual and reproductive health. I worked at Rainbow Health for about a year when I first moved here before I transitioned to my current position at YAP. My new title, to better inform the community on what I do, my new title is the Community Engagement Specialist. The Community Engagement Coordinator at YAP. So I do all things prevention, education, and outreach. And I get to hang out with folks all day, like Raquel. So that's kind of nice. And then I'll let Raquel introduce herself as well.
Thanks, Cree. So my name is Raquel Paulson. How I got into this work. So I am a Gary, Indiana born young person, I will say. And I moved here when I was 7 years old. You know, I had a very unfortunate upbringing. I was a part of the system and things of that nature. I was emancipated from the state of Minnesota when I was 18. I actually was, like most African-American folks that I think I know, didn't really go to the doctor. So I didn't have a sniffle or a cough, so I never went. And so I had been tested before for things, and I had given blood. So I think that was kind of how I figured out, like how I figured I was okay, because they took my blood. So I never ever officially had like an actual ever HIV test until kind of like Cree. I had my first official one. And that was really the only one that I ever needed because I was diagnosed positive back in 2007. I was diagnosed at the time that they were not starting people on medication right away. So I actually didn't start taking meds until I was about 6 years into being diagnosed positive. At that time, I also did not live my life as a trans-identified human being. I lived my life as a gay man, and I also didn't really pay too much into it. Like living with HIV for me was really a non-existent thing. I wanted to forget about it at all costs until I had to start taking the medication was when I remembered that I had HIV. So getting into the field was kind of a whim as well. I was actually in chemical dependency, and through a friend who worked at what is now Rainbow Health, he was like, hey, there's this grant. I think you'd be great for a position. I think you should apply. And so I applied and I actually got the job. And what was really cool about a lot of my trajectory is that I've kind of put myself in places that I have experienced already. So my trajectory is all lived experience. I have no education as far as like schooling goes. I am a person that suffers with chemical dependency, a person that lives with HIV. I am a person that is trans. So I'm a person that partakes in all of the resources that we talk about on a regular basis. I am that person. I just happen to work alongside you all and get to talk and educate the community in a really impactful way, which is really awesome. So it was a blessing that I got to meet Cree because he actually educated me so much more about HIV and what it was to actually be a person living with HIV even. And that is really, I mean, he was my kind of inspiration to really kind of start digging into this a little bit more and actually starting to educate myself a little bit more on what I had been living with for 13 years, you know what I'm saying? And so as a person who was a part of, from this state, I really didn't take part in a lot of the things that we're gonna talk about today until I started working in this field, which was what, 4 years ago? 4.5 years ago. So, you know, I've just been really honored to be working alongside him because he has educated me and opened my eyes up and introduced me to, you know, the tables that I've been so grateful to sit at because my voice was finally heard. And I think as a trans woman, not a lot of our voices are heard because we're not ever allowed at the table, or we don't know how to get to the table. So it was just really an opportunity for me to be able to like have that voice for our community. So I'm really honored and thank you guys for having me here today.
No, and I think that's a great point, Raquel, in talking about, you know, not always having access to the table, right? And in many ways, we didn't have access to data because for a long time, and still to this day, the way we sort of collect HIV data is based on the sex assigned at birth. And so a lot of the data around HIV and what would be beneficial and helpful to trans folks just isn't there. And so actually the CDC for the first time last year issued a report on HIV and transgender and gender non-conforming folks. And it wasn't from their own data, right? They used data from 88 surveys and research projects that they analyzed and went through to create their sort of guesstimates that they did. Because even when we submit the data to the CDC, it's typically done by sex at birth. So I do want to talk a little bit about the numbers and HIV since we're here to talk about numbers, right? So there's about 1.2 million people living in the United States, estimated living in the United States with HIV. The guesstimate is that about 2% of The people living with HIV in the US are trans or gender non-conforming, which would be somewhere between 20 and 25,000 folks. I think that's a low estimate, but I also believe that's based on how we collect data. Here in Minnesota, there is about 9,200 people living with HIV. And based on some of the work that we've done, we finally got a trans number. There's roughly 125 trans or gender nonconforming folks in Minnesota living with HIV. And I say finally because it wasn't that, our state epidemiology folks weren't trying to, do their best to collect the data, but to have a large enough sample size was the issue, and you need 100. That's typically the magic number in our world. You need a sample size of at least 100, and we didn't have that until a couple years ago after we started doing some of the work that we were doing. And we know that, trans folks, particularly trans women, have higher rates of HIV and other sexually transmitted infections. And it's because, we don't always access, like Raquel was mentioning in her own stories, that we don't always access medical care. And when we do, a lot of us, it is for our gender reaffirming part of our identity, right? And so we don't think about sometimes preventative health and sexual health, but that's important for us as well. And some of the reasons why trans folks and gender nonconforming folks have HIV at higher rates is because we're more likely to be unemployed or underemployed. We're more likely to face housing discrimination and housing insecurity, and more likely to deal with some mental health issues. And because of those issues, we are more likely to partake in things like drug use and survival sex as ways to sort of get through our lives. And those things also put us at higher risk for getting HIV. So back in 2018, so I wanted to mention that I was from Louisiana for a particular reason, and it is because I communicate differently than most folks in Minnesota. And that is sort of where our journey of data starts, is me being a little brat, right? Because I don't mind confrontation. So for AIDS Action Day a few years ago, I think it was 2018, we were getting a report on, some of the data and some of the information that we'd be giving to our legislative body around HIV. So a couple of us asked, hey, where's the data for trans identified folks? What are the numbers? Like, how can we speak to it? And basically the person who ran the HIV STD TB division at the time was like, oh, we don't have that data. That's not how we reported to the CDC. And so I can't help you out. And so I decided to push back. I was like, what do you mean? You don't have that data, you don't collect it? Like, I'm confused. Like, trans people have HIV, trans people in Minnesota have HIV. So we need to be better at collecting that data. And we went back and forth. It was a whole tiff because, Cree doesn't mind. Again, I don't mind confrontation. But I left that interaction feeling very frustrated and very hopeless, right? Because it's like, just because, the CDC doesn't it didn't mean that we as Minnesota couldn't be better, right? And an example of that, of how Minnesota is better when it comes to data and when it comes to HIV data even, is that because we have a large African immigrant population, we actually separate Black Americans from African-born folks when we're looking at data. But when we report that, we just report it all as Black people, like, to the CDC. So my thing was that even though the CDC collected data in one way, it didn't mean we couldn't be better in our data collection and then just reporting it in the way that the CDC wanted. So I left frustrated. But about a month or two later, Raquel and I were we were both part of the Minnesota HIV Planning Council at the time. Currently, only I am serving on it. Raquel isn't on it. But we received a presentation of the epi data around HIV from our state's epidemiologist. So we proceeded, myself, Raquel, and our friend Odie, who we were the three transgender nonconforming folks on the council, we proceeded to ask those questions I had asked for AIDS Action Day again. This time though, we got a different explanation on the why, right? And we got some feedback and information on how to try to go about collecting some of the data. And so we decided, and we had a vessel to do that too, because Raquel and I served, and Odie served on the Disparities Elimination Committee for the HIV Planning Council. And that committee is really in charge of taking a look at communities who are disproportionately affected by HIV and how can we get them better connected to Ryan White services. And so as a committee, we got together and started an ad hoc group of me, Odie, and Raquel, because at first no one else wanted to join us. And then after we were talking about the work that we wanted to do or wanted to accomplish, what made me kind of sad is that only the Black people joined us from the council. And it's because they understand the importance of being recognized in the data. And so for those of you who don't know, when it comes to HIV, the way you get money is having data, is having numbers. And so in order to really create programs and reach trans folks, we had to have those numbers. And so we knew that there was more than 100 Minnesotans who identified both as transgender or gender nonconforming and someone living with HIV. So we decided to start meeting. Raquel, do you want to talk a little bit about why we started meeting?
Sure. So so as Chris said, we started meeting mainly to figure out the best way to go about reaching the community so that we could start collecting this data, because we knew that we weren't going to necessarily get all of the providers on board to start doing this right away. So we figured, let's start meeting, get creative, figure out like what the process is. And at first we kind of just started with our we were all kind of testers or prevention folks. And so we already kind of were collecting data in a way. And so we're like, how can we start collecting data in a way that we can show them that it's easy to collect the data? And so then, as Chris said, Jared, who's an amazing epidemiologist, was like, it's pretty easy. This is what you guys need. And so he's like, you just need their first name, their last name, their chosen name now, their sex and everything like that. So just basic demographics. And so, like I said, we were creating our own forms, trying to figure out this. And he's like, no, I've got something for you guys. And so the meeting was just really to figure out what's the best way to go about this. And so some of us, like Odie, who she's ride or die, she was just taking the forms to like parties and places that she was going and people that she knew, and she was having them fill it out. And I know some of us were trying to do it within our own little cohorts and stuff, but I think initially we were able to get each organization that was sitting at the table at least to fulfill the need that we were asking for. So
yeah, and the way that got kind of easy from Jared was that he already had a form. And then he was like, actually, I can just make it easier to collect that data, right? And so for us at YAP, we simply collected all of our trans and gender nonconforming youth. And so like Raquel said, we needed to collect their dead name because it still might be on legal documents, their name, their date of birth, their assigned sex at birth, and then their current, like their gender identity. And so Jared made the process really easy. And through the process, we realized part of the problem is, or the major problem is, because Jared and his team can sort of figure out, if all of the information is there, can figure out who is at trans, right? They may not get it right if you identify as, gender nonconforming, but it's because not everyone reports gender to the state, even though it's part of the form. So they'll put the sex at birth on the form, but they won't put like gender identity. And so for most people in the state of Minnesota living with HIV, not just those of us who identify as trans or non-binary, but most of us don't have a gender listed in the state database. And so we went out, OD, like Raquel said, OD did events and agencies submitted their names. Mine was youth because I'm at the Youth and AIDS Project. And then we finally got in the numbers, right? Like it's a little tiny sliver, but we are now in the numbers and we can now have discussions, and we can now, in my role, on the planning council and working with Ryan White, we can start allocating like funds to begin addressing some of the needs for transgender folks. And I think part of the problem is that because we collected it by sex at birth, I think it showed a discrepancy in how people view sexual orientation and gender identity as almost the same thing, but they're not. They're completely different. So I think they just assume that like Raquel and I had the same sex partners, right? And we don't. And so, we were getting like me and my sex partners, but we're retesting trans women's sex partners, right? And then oftentimes we erased trans men out of the equation, right? Like, I think people assume that once, someone transitioned into transmasculine, that their partners were all, cis women, when we know that's not the case, because some transmasculine people don't identify as, straight, right? And so it just messed up a lot of our data. But the data we do have now, I think is still significantly important, because I also find it very interesting that Raquel and I are having this conversation as Black folks in a predominantly white state, because it's still people of color that HIV is affecting the most. So even though our rate of infection has stayed pretty much the same in Minnesota over the last 30 to 40 years, because of our growing diversity in the state of Minnesota, the new infections are becoming browner and younger. So we're seeing a lot more young kids of color getting HIV here in the state and across the United States. With the introduction of things like PrEP and U=U, we've seen the numbers for white gay men go down, but we've seen the numbers for Black and Latinx gay men, or men who have sex with men, continue to rise. And that number is trending the same way based in the research that has been done at the CDC as well. And like, trans folks of color are bearing the brunt of HIV, just like their counterparts. The numbers are the same. So it's estimated about 44% of Black trans women are living with HIV, which is very similar to their Black men who have sex with men counterparts. So for Black men who have sex with men, it's estimated 1 in 3 will have HIV by the time they're 35, and 1 in 2 will have it by the time they're 50. So we're seeing that the numbers are trending in the same ways and at the same rates for our trans femme counterparts. And I think that, I think that it is important because, what is putting them at risk is not just about who they're sleeping with, but it's about other aspects of their lives that, are putting folks at risk. And so, I mentioned things like, poverty and, economic hardships, but also, just lack of access to quality education and medical care also increase, our chances, and medical mistrust increase our chances of getting HIV. And so at YAP, about 1 in 7 of our clients identify as trans or gender nonconforming. And so we're beginning to think about like, how do we best serve those folks? I think it's really amazing that, a lot of those young people will have representation in staff, which is really helpful for them because they see that, like with Raquel and I working there, they see that, they can live life fully, right? And that, HIV isn't a death sentence, and we can sort of work with them to help them accomplish like what they need. And so that's basically and then what do you do? How can you help? Oh my, it's been a long day of Zoom meetings already. So how can you help, right? So if you are a trans person or a gender nonconforming person living with HIV and you want to make sure that your data is correct, you can reach out to myself or Raquel, and we can get your information and collect all the things from you, so you don't have to fill out those forms and try to get, the secret emails to get it to MDH. And so we can help you figure out that, like, help you through that process. And then if you are a provider, also start to think of, and I guess Raquel wanted to pose that question. Never mind. I'll let Raquel pose that question in a second. But if you're a provider, I think it's important that, you begin to look how, and you work with people living with HIV, maybe ensuring that their gender has been reported to the state, so that way, Jared and his epidemiological team knows that the person that you're serving is someone who's trans or gender nonconforming. But Raquel actually had a question that she wanted to pose to providers, and I think that'll help us start a nice chat dialogue.
Yeah, so another little backstory. I know I had some of my old coworkers who just presented before me, Dr. Pariser and Dr. Carrie Link. I was the trans care intake coordinator for the CGC for about 6.5 months. And one of the questions that I always proposed to not only the surgeons, but everyone else that I worked with that had a higher pay grade than me was, what exactly is it that you want to do, or what can you do to make our lives as trans folks better? How can you be a pioneer? How can you be the one, kind of like Chris said, I always feel like we are the ones that have to fight the battle for ourselves. And it would be nice sometimes to kind of take that back seat and kind of see the providers, the ones that can make the decisions and can make the change, because we can suggest the change always, but we're not the ones that can make the change. So I guess the question again is like, what are
you doing as providers in your places of employment? So whether it's a clinic or a community-based setting, what are you doing as providers to ensure that, trans folks are both served well, but also are represented in staff or in data or in numbers? Like, what are some things that you might do at your office to help this issue? Feel free to jump in. I mean, I know I'm cute, so I'll keep looking cute for y'all, but y'all know me, I like to have conversations. So if there's anything that you have questions about, feel free to ask. And if not, y'all have been, staring at a screen since I think 10 o'clock this morning. So this session can be a short session too. We just wanted to let folks know about our efforts. And if you are trans or someone who is trans and living with HIV, just connect them with us and we can make sure that their data is updated in the system.
This is Hannah. It looks like we do have not a question, but a comment in the in the Q&A that I'll just share. So it just says, no question here, but I wanted to personally acknowledge the interpreters, Terry and Sam. Thank you for your time today and all the work you do for the ASL community.
Oh, someone asked for my email address. So my email address is a little bit easier than Raquel's because it's just my first name. So Cree, C-R-E-E at umn.edu. And Hannah, feel free if folks are asking about our emails afterwards, feel free to give that out to folks.
Definitely.
Well, that's it from us. We're working hard to make sure we're represented in data. I'll hand it back over to the moderators and the event organizers. We'll keep it simple for y'all.
Thank you so much, Cree and Raquel. Super appreciate hearing from you and seeing your lovely faces. Thank you all so much for coming to this event. I know this session was cut a little short, but feel free to hang out. Feel free to go to our website, find out more. So we did just get a question. I actually wonder if I could throw this back to Cree and Raquel.
Okay.
Even though I am wrapping up, we have a question in the chat. As far as next steps, overall, and I'm happy to provide some insight here too. How can we as providers become more involved in the community?
I mean, it's just finding out, like, everywhere you go and you refer people to, just go and spend a day or spend a couple hours and volunteer, get to know the organization better. A lot of times we know like one resource at an organization, but there's probably like 20 things we could refer people there for. And so oftentimes we just don't know the resources, but I feel like you can go and, just get to know folks. One of the things we are also doing at YAP, which it'll help YAP in the short term because we have a small staff, but it'll help the community in the long term, is that our new medical director has more time dedicated to helping YAP. And so we're trying to figure out a way, it's in the process of having residents come through YAP and support some of the services like at YAP, but also like in the community. Now that we're post-COVID, we're trying to think about how we're going to set up a youth STD clinic in partnership with the clinic that our medical director works at. And also, I was thinking too that maybe some of these residents could be helping at some of the syringe exchange sites, like in the community. So like, if you are a provider and you want to help out, like it's literally just reaching out. I don't think any of our agencies would say no to a little help every so often.
Yeah, do you have anything to add, Raquel? No worries if not.
Oh, no, not at all. I think that's great. When I worked at Rainbow Health and I was working in the syringe exchange, partnering with providers that were eager to see change in those fields, I think is great. And I think that's the most important thing, is if you are on board and you like what you heard and you think that this is a great idea, then you want to start making that movement. I think absolutely finding the agencies, calling Cree, emailing us, whatever, and saying, how can I help? And I think that's really the first step, and we sit down at a table and we figure it out. But just going and doing it, I think, is the easiest thing.
Yeah, definitely. And I'll add too, at Rainbow Health, we do also provide education for care providers. So, not just like this conference, but, you can also reach out, find out if if we can come and provide a training for you and your staff, or sometimes we have ones that are just offered for individuals to sign up for. So if you go to our website, you can find out more about those opportunities. But if you're wanting more information like this today and more information about, ways to be more competent in care for both people living with HIV and people who are LGBTQ, that's something that we can also offer.
And then,
have another, or are you talking about that one, Cree?
Yes, I was going to say, so we report to, so there's a question about how to report a patient's or a client's gender to the CDC or to MDH. And so the thing is, we report to MDH. So that's where the change will actually come, because the CDC gets all of its data through what the states report, and there's a couple of different systems we put data into that the CDC can then pull from. So we change it at the state, so we'll change it at MDH. And then if you shoot me an email, if you do have patients or clients who you would like to check their, or you would like to report their gender, there is a form that I can, if you send me an email, I can shoot you the form. Or if you are like a provider at a clinic, I could put you in touch with Jared Shank, our state epidemiologist. And if you want, like, if there's like a mass, sort of send, he can give you an easier way to sort of upload that or report that to him and his team. So again, Hannah, feel free to shoot people my email address. I'll put it in the chat because the person asked both in the Q&A and in the chat. Yeah, just shoot me an email and I'll connect you to the right channels.
Amazing.
Oops, I send that directly to Tia, not all panelists.
Amazing. Thank you all so much. Thank you, Cree and Raquel. So now we're just going to hear from Miko again, and I appreciate all of you being here. Thanks.
Bye, Hannah.
Thank you all for spending your day with Rainbow Health. A final thank you to our sponsors, Alina Health, New Way, Right at Home, Walmart Pharmacy, and Target. To achieve health equity here in Minnesota, it will take advocates in every sector. I also want to thank the folks at Stage Time Productions, AV for You, and Vid Guru who made today's event possible. Finally, thank you to all of our incredible speakers. Please visit bit.ly/2021 Transforming Care to learn more about today's speakers. Make sure you've registered to receive access to the session recordings and show your support for Rainbow Health. Once again, I'm Miko Blaze. Thank you so much for joining the 2021 Transforming Care Beyond the Binary event.